to serve as your mistress of ceremonies, because Laverne knows I couldn't miss this for anything. And I really appreciate the opportunity to be here with everyone, welcome you to the Virgin Islands Department of Health, Health Disparities Program, Health Equity Summit. That's a mouthful, but it is an amazing program we have in store for you. And this Disparities Program is funded by a CDC grant. We always want to acknowledge our funders and our supporters of everything we do here at the Department of Health, in addition to the support, of course, we get from the local government to make sure that we continue to provide the services that are so critical to the community. And working towards achieving health equity is a critical function that the Department of Health, and you will hear very soon from our commissioner, that this is something that we are taking very seriously, have always done it, but putting more intentional actions behind it, so that this Health Equity Summit is an opportunity to widen the education, bring information to a broad base of all our partners who have already been working with us at the Department of Health to bring us closer to achieving health equity. So at this point in time, I'd like to bring up none other than our Commissioner, Justa Tita Encarnacion, to bring remarks.
Thank you very much, Dr. Valmont. And before we start, I always do this, and she wants to know why I do it, but I always want to recognize our former Congresswoman, Donna Christensen, who is here with us today and always a part of our team. Thank you so much for being here and being part of us. Well, I'm happy that we have this and not stuck to that. So that is very, but you want me to go over there? This is better? Okay, good. Okay, so rather than me speaking about health equity, I'm going to ask each of you to give me a little thing about health equity. You know why? Because health equity could mean something to me, and it's going to mean something completely different to you. Since I have to stay in the light, can I ask for 10 volunteers? Because there's a lot of people, and plus, first of all, good morning. It is wonderful to see not just a few, but many individuals in this room talking about something that is near and dear to my heart, to Dr. Valmont's heart, and to the executive team's heart. And it's something that we need we would like to transcend throughout the Department of Health. And today, this meeting isn't just about the Department of Health, even though, you know, we're that good, we're great. This meeting is about our partners. So one of the things that I'd like to do is first, let's just, 10 people raise your hand, and if I may, walk to you, and I want, oh, okay, good. And for you, tell me two things. One, tell me what you think health equity is, in your words, and then define health, which may be different. So the first 5, tell me what your definition of health equity is. If you don't raise your hand, I am going to call your name because I know many of you. Okay, Clint Ferris, where is he? He's saying, did she really do that? Mm-hmm.
Yes, ma'am?
Clint is my brother from UVI, guys, okay?
I do not have a response to your inquiry.
So what does health mean to you?
I know what it is.
Okay.
I really can't tell you.
Okay, let me ask. This is great. Thank you so much for doing this. I see I chose the right person. If you say that you want to be healthy, what would it take for you to be healthy? Don't think of anybody else, you know. Think about Clint Ferris. What would make Clint Ferris feel like he is healthy?
One, I would have to lose a few pounds. 2, eat right. Mm-hmm. I like rich foods.
Okay.
And I like to indulge in a few things as well. So I know I'm going to have to do a few things in moderation. So the Johnny Walker Black, the Crucian Rum, we'll have to put that minimize that.
I didn't tell her you chose the right person. Okay.
I'm a Caribbean man. I like I like my bread. I like my sweets. So again, reducing some of those stuff, and some of those things I've already started to do. But you're gonna have to take the saltfish out of my hand when I'm dead. Saltfish, pork, and all those things I eat. So I'm gonna tell you that even the red meat, I like that too. So
Well,
everything is in moderation.
excellent. Okay. Thank you so much. Any more volunteers? Or should I voluntold you again? Lisa Charles. I see Lisa Charles. She's a beautiful lady with braids in the corner.
Can you repeat the question?
Would you like me to spell it?
No, so health, okay. Health disparities mean the availability for everybody to, equity. The availability for everybody to get the same health care regardless of how much you make, how much you don't make, so that, it's across the board. I can go to the same doctor that Governor Bryan can go to and stuff like that. That's my definition of it.
We'll tell him you said that, okay? Okay. Oh, we have Dr. Dizan right there next to you. Dr. Dizan?
What's the question? Same question?
Same question.
What is health, or what is health?
Define what is health to you, Dr. Dizan.
What is health to me? What I tell my patients is to live a healthy life. And so it's making choices that you are physically healthy. We know what we need to do. We're told all the time how to eat, exercise, mental wellness is also a part of it. So it's behavior, what we're supposed to do, how often should we see a physician, how often should we check in with ourselves, self-care. That's all part of healthy living. And then the doctor tells you about the science part, and Dr. Ellis does the same. So it's a combination of, it's a collaborative effort on your part, as well as the people you trust to tell you what you should be doing, and how you perceive yourself. And it's convincing people that they have to make choices that maybe not drink as much rum, Johnny, and Coke and rum, and saltfish. So
I think you're speaking to
it's
someone
choices.
in this room.
It's making choices and knowing what your options are and the consequences of your choices for living a healthy life, physical and mentally.
Thank you. Nicole. Dr. Nicole Cragwell-Sims, Assistant Commissioner of Health.
Morning. To me, health equity is blind health care. Not to turn my back to y'all, but blind health care. So what that means is regardless of what you look like, social, economic status, you receive health care. And health to me is, hair follicle to toenail care. So that includes mental health, physical health, emotional health, all of this stuff wrapped up in a nice little bow, which is you.
Okay, thank you. I like that. Anyone else? May I have one of those? Dwayne. That's Dwayne? Mr. Howell? Thanks for being here.
Morning, everybody. For me, health equity is about closing gaps, about ensuring that we could accommodate people where they're at, and creating those bridges so that everybody is on the same playing field, no matter where they're at. And health is, for me, it's if you're doing good emotionally, physically, mentally, spiritually, it's really comprehensive in how we think we're good. Beyond just our eating and exercising and all of that, we still have to have the motivation. So being healthy is really about having that intrinsic motivation to really push on, move on, That's how I see it.
Good. Not just wake up every day, but wake up with some energy, some motivation, knowing what's going to happen, or at least planning what's going to happen next, and taking control. If you notice, a lot of similarities actually occurred. Dr. Dizan spoke about the things that we need to be able to be healthy. Mr. Ferris spoke, Clint spoke about things that maybe he knows he needs to work on a little bit. So he identified some of the characteristics of not being as healthy as one could be. But Dr. Dizan is in the room, so before we finish, we're going to have an appointment for Clint with Dr. Dizan at our community health. So basically, everyone has excuse me? Okay. I'm here, so I'm going to have to let him use this.
Like everyone has said, and the commissioner has reiterated, everything that everyone said is correct. But I'd just like to add one little component to it. The term equity could be misunderstood in this context, because it's not about everybody receiving the equal care, it's everybody receiving the care that they need. So it includes, as Dr. Sim said, our vulnerable populations, that they receive the care. I may not need, hopefully, as much mental health care as, yes. Okay, I'll be a straight man. But you got the message.
Thank you so much, AC Malloy. I appreciate that. So let me welcome. Good to see you. I just want someone to raise their hand. Just tell me, for our partners, not DOH, but for our partners, I see a few people in here that is outside of DOH. Just raise your hand, tell me, shout out where you're coming from. Go ahead. For sure. We were talking about when VI perinatal health was aired.
That's right.
Just yesterday.
VI.
So.
And that was our initial mandate, was access to care.
That's right. So
and addressing health disparities.
We spoke about that yesterday and how we can work together. That was one of the questions from chronic disease, right, Dr. Fredericks? So that connection is now made. So
and
that's
I just
wonderful.
wanted to say how much I agree with A.C. Malloy, because he's absolutely correct. Because when you think of equity, I don't need the governor's doctor. I just need to have the same quality of care and comprehensive care. Because the way our society is structured, I can't afford probably the doctor that he goes to. And we don't have that level of equity in anything else. But I would like to see everyone have access to quality and comprehensive care.
Excellent. Thank you. Thank you for that. And hopefully we can all afford whatever doctor anyone goes through. And that is really and truly what the goal is. Someone in the back had his hand up.
Hi, good morning. Dwayne Strawn from Massa Assist.
Massa Assist?
Yes.
Thank you very much. I know we have Department of Education in the house. Okay.
Good morning, Rena Francis, Department of Education.
Thank you.
Clint Ferris, Department of Education.
We're not necessarily a partner, but I'm coming from the Virgin Islands Bureau of Internal Revenue. I'm here hoping that I could walk away with something brand new. I've learned something today because I myself have been diagnosed with different ailments, to include an autoimmune disease. And apart from that, where I work at the Bureau of Internal Revenue, a lot of people, after coming to visit our office, leave with their pressure up. So
That's why I love her. You're all from IRB? IRB, and where are you from? Okay, okay. Well, okay, tell us your name, because that's actually, that we should praise you for just being here.
My name is Verna May Dawud.
Okay, a retiree. Excellent. We all wish to be there one day.
So,
Okay, so
good morning.
Thank you all for that.
Good morning.
I'm so sorry.
Hi, good morning. Christensen Institute for Community Health and Empowerment.
Thank you very much, and congratulations. That is a nonprofit that Dr. Christensen has, and she will be collaborating with us in reference to decrease in health equity, or increase in health equity, decrease in disparity throughout the territory. So we're very encouraged by that. I want to read for you, and like he said, this is CDC's definition of health equity, but everyone has a different definition of health equity. Health equity means ensuring that everyone has a chance to be as healthy as possible. However, factors outside of a person's control, such as discrimination and lack of resources, can prevent them from achieving their best health. Working together, health equity is a way to correct or challenge these factors. So I have to tell you that one time I went to a conference, I think it was in Colorado, and they spoke about social determinants of health. And how do you actually tap into those social determinants of health to improve health in the area that you are living? And one of the things that the goal is to work very closely with the Department of Human Services. Right now, Department of Human Services houses the Medicaid state plan. And my goal is to be at the table working with Department of Human Services. We have a great relationship, and we're going to continue to do that, and to really tap into the health disparities throughout the territory. And I always give the example of asthma, and the reason why is because my family has asthma throughout. My brother died of asthma, and many people know that, but he did. But people with asthma, younger children, they may not have access to finances, which also is a social determinant of health. They do not have the finances needed, so they may be living in a house with a lot of dust. They may be living in a house with carpet that is moldy. And so working with someone like Human Services that has access to Medicaid funding, we should be able to tap into those funds and have those rugs removed, have those rugs cleaned, have a house cleaned. And why is that so? Because that is that little boy's social determinant of health. That is what's determining for him whether he stays healthy or sometimes hospitalized because he has asthma. That's just one little example. But the goal of, and we have community health workers in the room, and I know all day long you're going to be hearing so many things, but I want to recognize our community health workers in the room. So big up, community health workers. A very, very special part of our team. And we know we're going to expand upon it. I always talk about the time, when we were little girls and little boys, right, Ruben, I can't forget your boys. And we were in school, and you had nurses, and you had nurses' aide coming to your school, and they're asking you questions, and they're there with you. That's our goal. Sometimes people say, well, you did it already before, you shouldn't do it again. Sometimes you have to go back to go forward. And the Department of Health is, along with you, our partners, because we can't do it ourselves, and yes, you are our partner. And we cannot do it by ourselves, but we are going back, holding each other's hand, and we're going straight ahead because we're going to get as close as possible to overcoming our social determinants of health and closest as we can to health equity. Thank you very much. Congratulations to you. This is the first Health Equity Summit that we have had within a territory. So to the office, or where is Director Laverne Marsh? Thank you so much for being the director over the Disparities program. And of course, Dr. Valmont for working with me on this project as we really and truly promote health equity in the Virgin Islands. Thank you all.
Thank you, Commissioner. Always on point and a very tough act to follow, but Irvin Julian, it's your turn. I just want to let everyone know Irvin now serves as a public health advisor with CDC, but he may not tell you this, but if it was not for Irvin, we would not have received this grant at all. We got a very short notice, apply. Irvin spent hours, applied, and we got awarded, and then got the opportunity to actually increase our award. So thank you, Irvin, and please bring remarks this time from CDC.
Good morning, everyone. Thank you, Ms. Valmont. It's so great to see so much beautiful faces here this morning, isn't it? To discuss a heavy issue. We think it's heavy, but it's not heavy. I would like to thank the Roach Bryan administration for the continued support with this endeavor. I would like to thank Commissioner Hussein Khanis-Young for taking this by the horn and making sure that we address health disparities in our community. So, Commissioner, thank you. Assistant Commissioner Malloy and Assistant Commissioner Sims, thank you as well. Like DC Janice Valmont mentioned, this grant means a lot to me because I signed from the very beginning, and I think we had about 2 weeks to apply for it. And even though she may want to give me credit, I can't take the credit because it was a team effort with the assistance of everyone and every division. And we were awarded the grant. So now we can address what has been plaguing us, which is disparities. What does it look like? What is it? So what I would like to see happen today is a myriad of conversations with each other. And let's make it more personal. I can tell you what it is personally for me. My dad died March the 16th of this year. Heart disease. Lack of services. If we were in a different location or had the services, then maybe that story would have ended differently. And that's why this opportunity that we have is important. I would like to thank our community health workers. You're the voice for us. You're going to go into the communities and ask your neighbors, your loved ones, your family, how can we assist? That's what the Department of Health is here to do. That's what we got funding to do. And that's what we are going to do under the leadership of Hussein Khanis-Young and the support of the Brian Roach administration. The team is phenomenal. We received the grant, but the work is you. We need your help. We need your support, our partners. That's why you're here. ARC Institute, VI Partners for Healthy Communities. We need every last one of you. Money is just money. It comes and goes. We need the work and the help and support of you. So what I would like to see accomplished today is detailed conversation about what does health disparities look like in Williams Delight? What does it look like in Wim? What does it look like in Machuchal? It's the places you live. And how can we assist and help our neighbors, our community? I love the whole healthy me, healthy family, healthy community. And it starts first, healthy me. So we have to take care of ourselves first, right? They said that on the airlines. You put on your mask first, and then the little children, them, if you don't want them, well, forget them. But you take care of yourself first. And then we take care of each other, right? And then we'll be able to take care of other people. But it starts with us. It starts with you being here today and addressing this, because it has to be addressed. Now, Commissioner Khanis-Young did part one, which was championed and rallied to ensure that we address this. So she did part one. Today, we're going to do part two, which is to have those uncomfortable conversations about diabetes, asthma, heart disease, smoking, you name it. Let's have these conversations. Everybody have a neighbor who have high blood pressure. A lot of people can afford medications for that. That's a social determinant of health. Now, I am going to challenge everyone that's here one thing. We worked really hard to get this funding for the VI. We really did. Now we're going to take this funding, which was over $3 million, and we're going to put it in your hands. I'm going to charge each and every last one of you to help us, to help someone else. So before I close, I would like to say a very special thank you to the OT 21-2103 team, Director Laverne Marsh Cole, your program managers, Mr. Keith James, Ms. Davaline Trusty, your community health workers. They're going to be the bloodline of this grant. I'd like to thank all of DOH staff, because it's all of us, right? Because we said healthy we, right? That's what's in the book, right? So I want to thank you guys for an awesome job that's done. It is the first Health Equity Summit, and because I don't want my story to be your story with a loved one not receiving services, it's not going to be my last time that you're going to see me. We're going to use the funding that was awarded by CDC, Office of Island Affairs, and we're going to put it to work. And we're going to address what the commissioner have been fighting so hard for. So it's Healthy Me, Healthy, okay, and then Healthy, okay, so, yeah, a little bit louder, Commissioner. Healthy, healthy, healthy. Thank you guys so much. And you just pledged. So before you leave, please get in contact with Director Marsh Cole. If you are not signed up yet for their emailing list, the whatever, we need your help. We can't do it alone. Because we said healthy, healthy, healthy. So we have to protect each other. So thank you guys so much for being here today. And let's have a great summit. Thank you.
Thank you, Mr. Julian. And without any more hesitation, I'll bring forward Laverne Marsh Cole, who's our director of the Disparities Grant Program, to bring some remarks before we get into our first block of presentations on Healthy Me. So if you notice, this theme was developed by the program, and it really ties immediately, completely into the socio-ecological model of health, where we start with the individual, go to the next level, the family, then the community, and the policy level. So the health equity piece that will close out the day will help us wrap things up a little bit and kind of give us some sense of direction where we need to go. So Director Marsh Cole.
Thank you, Dr. Velma. Good morning, everyone. I thank each one of you for being here today. Reiterating Healthy Me, Healthy Family, Healthy Community, rounded out by Health Equity. So when you talk about health equity, what does health equity mean? Commissioner, this morning, asked everyone, what is your definition of health? What is your definition of health equity? I'm going to take it a next step, Commissioner. Anyone in here who has a family member that passed away because of COVID, please stand. Anyone in here who has a family member who was diagnosed with diabetes, please stand. You or your family member. Anyone in here, you or your family member has been diagnosed with pressure, high blood pressure, please stand. Anyone in here who has had to travel for health care, please stand. You or your family member. Anyone in here who wants to achieve better health, please stand. Now, when we look around this room, 99% of people are standing. This is what health equity means. It's not equality in health. You could sit. It's offering people the resources that they individually need to achieve their best health. Equality is sometimes mistaken for equity, and I wanted to dispel that. Equality is everybody gets the same fruit. Equity is, I'm allergic to mangoes. Why are you giving me a mango? It will not work for me. I'm allergic to pineapples. Pineapples will not work for me. So you giving me the same fruit does not equate to you helping me. Equity versus equality. I wanted to extend sincere thank you to my staff. We are small. I call us the little engine that could. Our grant was awarded in June of last year. Most of the staff came on between February of this year and May. And in that time, we were awarded initially $3,114,000. Remember that number, $3,114,000. From February to now, we've had 76 separate outreach, my small staff. We have dealt with or addressed over 15,000 Virgin Islands so far. St. Croix, St. Thomas, St. John, and Water Island. The summit plan was instituted by the entire staff. All of us worked together. It wasn't a matter of the director or the managers. What I did is I asked the staff, who wants to be in charge of a committee? People volunteered, my staff volunteered. And they took over and they ran with it. This is our summit. This is your summit. This is our summit. I wanted to recognize the chairs of some of my committees, and I wanted to recognize my staff in general. But I wanted to specifically thank Ms. Koya Richards. Koya's in the back. Koya was in charge of coordinating our presenters. Ms. Kibibi Jackman, who was in charge of our logistics. Both Koya and Kibibi are actually community health workers who stood up and took charge and took the responsibility of being chairs of these committees. Fabian Tobier, who is our information specialist, health informatics specialist, he took over for registration. And Shanae Abraham. Shanae Abraham was in charge of our booklet. Yeah. Okay, so I individually thank everyone who was chair, but I wanted to not only share this opportunity for everyone to see me, of course, but I will ask all my staff, all of the health disparity staff, to please come forward and join me up here so we can acknowledge the fact that you have been doing a phenomenal job. So I'm going to introduce you to them one by one so that when you see them in the community, this is the Health Disparities team. Ladies and gentlemen, this is the little engine that could. This is Kisa Harris, our administrative assistant. Crosby. Dorothy Smith, she's a community health worker. She's also from the St. Thomas district. Wanda Harris, community health worker from the St. Croix district. Kibibi Jackman, community health worker from the St. Croix district. Cameron Collins, who is actually a PHAP, which is basically sent from the CDC to work with us for 2 years. And she just fell in with our group. Fabian Touverier, who is our health informatics specialist on St. Croix. Koya Richards, like I said before, she is a community health worker from St. Thomas. Shanae Abraham, who is our compliance officer, she's on St. Croix. Lillian Jeffers, who is our fiscal officer on St. Croix. Lillian Jeffers, who makes sure our money is spent and spent correctly. A stickler. Keith James, who is our program manager on St. Croix. Daveline Trustee, who's our program manager on St. Thomas. Ladies and gentlemen, please, please. Thank you. Sure.
thank each and every one of you. And you know, you mentioned the word COVID. We try not to speak about COVID, but I have to thank COVID for, you talk about social determinants of health, we also need to speak about political determinants of health. Right, Dr. Christensen? And if it wasn't for COVID, remember, in order for us to get over, to be where we are now, everyone needed to get vaccinated in the world, not just in the Virgin Islands, not just in a nation, but in the world. So our government, our federal government, took the responsibility of saying we now need to address health equities from that standpoint. So it was because we needed to touch every race, every color, every religion, every ethnicity to get to where we are right now outside of the pandemic and into the stage of endemicity is where we are. And it is because of that we now have access to the Disparity Grant and all of you. So thank you. And thank you, CDC.
So who is considered the disparate population? We have seniors, we have homeless, incarcerated adolescent, but we have you and I. The Virgin Islands, we're considered a rural community, and because of our location, access to health care might be challenging despite your financial situations. So we may have the finances, but we still have to find ways to be able to get the health care that we need. So essentially, each one of us here is considered part of the disparate population because of our rural location. So when you think about disparities, it's not someone else's problem. It's individual problems, or it's all of our problems. So then when we talk about healthy me, healthy family, healthy communities, all of that combined will help to strive to health equity. And I challenge each of you, if you leave here with nothing today, leave with the remembrance that you are the foundation for health equity. It starts with you. Taking care of yourself physically, mentally, emotionally, investing in your health, making sure that you get your annual checkups, making sure that you follow up on your checkups, making sure you have a relationship with your doctor. These are important things for not just you, not just your husband, not just your child, back to you again. Take care of yourself. Thank you.
Thank you, thank you. So we have come to the part of our program where I want to thank everyone who has brought remarks. I think this has been a great way to get us going and get us started. And because I'm me, while Dr. Fredericks comes up to start the presentations on Healthy Me, I'm going to offer everyone the opportunity to stand, stretch. Let's do it. Stand, stretch, move around, because it's really critical to move.
Hey, good morning all. Again, I am Linya Fredericks. I work at the Department of Health as the Director of Chronic Disease. And I have been with the department about 6 years, about a year and a half in this role. And I just look forward to bringing you information from my division. I want to recognize two of my staff who are here with me today, Ms. Janesta Rader, as my tobacco program manager, and then Mr. David Delgado, my diabetes program manager. An overview of the presentation today, I'm going to talk a little bit, not too much about what health equity is. You've heard a lot about that from Commissioner and Director Marsh Cole. We're going to go over, it's going to be a little data heavy, so if you love data, yay. So we're going to discuss the census data, talk a little bit about mortality data, so the leading causes of death, and then we're going to, so the highlight for me is I'm going to be able to present to you information on the behavioral risk factor surveillance system. So we have current data, 2021 data, which I'll be sharing some of that with you during this presentation. Then I'll talk a little bit about the role of the Division of Chronic Disease and Prevention, a little bit about what we do, how we can assist with closing the gap, and how we partner with programs such as Health Disparities and other programs and organizations in the community. And then I'll do Q&A at the end like Dr. Baumann said. So, a healthy me. So I have a confession. It seems like the commissioner stole my idea. My intention was to have you reflect on what it means to be a healthy you, but most of you already did that, so you already were thinking about what you are, what your life looked like, being the healthiest you can be. So I was happy that she didn't call on me. So now I have the opportunity to share with you my version of a healthy me. So I would be someone who doesn't smoke, limiting my alcohol consumption, and some of these I'm already doing, and full disclosure, I have some work to do myself. I would be at a healthy weight, eating a balanced diet, so using the plate method, measuring my calories, doing all of that good stuff, exercising regularly, sleeping well, I'm feeling relaxed, so I'm stress-free, I'm in a great mental space, thinking positively at least most of the time, and having a good work-life balance. That's a struggle area for me. And having good interpersonal relationships. So that's my definition of me being at my best health, and of course having access to healthcare. Definition of health equity, just to frame the rest of the discussion. This one is a different version of what the commissioner said, but it's also taken from the CDC. Health equity is achieved when every person has the opportunity to attain his or her full health potential, and no one is disadvantaged from achieving this potential because of social position or other socially determined circumstances, which we refer to as those social determinants of health. Health inequities are reflected in differences in length of life, quality of life, rates of disease, disability and death, severity of disease, and access to treatment. And again here, the social determinants of health, which are access to healthcare, education, economic stability, social and community context, and then the built environment, your neighborhood, where you live, you're born, you work, you grow, you play. So I'm gonna just discuss the 2020 data so we can give a framework for the population. So when I'm talking about the rest of the data, you know the population that I'm referring to. So our population dropped. We are now at 87,146. That's the total population based on the 2020 census. And the demographics, as far as females and males, we have 44,803 females and 42,243 males. When we talk about gender, so the survey that I'm going to be discussing is focused on the adult population, so that's why I pulled out the data for adults. So when we talk about the breakfast data, right now we have about 68,109 adults, ages 20 and older. However, the survey is referring to adults 18 and over. And then I have it broken down here. We have a pretty close balance between females and males, a little more females than males. And then our population by race, of course, we know we have more blacks and African Americans. And then we have some persons who identify as Hispanic. Our mortality data as of 2020, and this is the number of cases per 100,000 population. The leading cause of death in 2020 was heart disease, followed by cancer, then Alzheimer's disease, assault or homicide. Number 5 is cerebrovascular diseases, followed by diabetes, and then hypertension and hypertensive renal disease. Okay, so the behavioral risk factor surveillance system. I'll give a little information about what it is. It's a chronic disease surveillance system that collects data to understand how social, economic, and other factors impact health. So it's a population telephone health survey. And I'm always going to do my plug. If you receive a call, please take the survey. So we are collecting 2022 data, but this is the 2021 data that I'm sharing with you right now. It's through random and anonymous sampling. So not everybody's going to receive a call. It's a random sampling system. And then we collect data on health-related risk behaviors, such as smoking, physical activity, and obesity, chronic health conditions, such as diabetes, hypertension, and cholesterol, and then the use of preventive services. So whether people are accessing mammograms, whether they're screening for diabetes, if they're screening for cholesterol. It is all self-reported data, so bear in mind, we ask you the question. Most of the questions preface with, have you ever been told by a doctor you have X, Y, Z? And then you respond accordingly. So let's get into the data now. I'm going to start with the diabetes prevalence data. So our prevalence in 2020, as of 2021 for diabetes, I have the USVI at 14.9%, and that's in comparison to the US. That's the entire US, DC territories at 11.1%. So we have a higher prevalence of diabetes in comparison to the United States. Then when it's broken down by race and ethnicity, Blacks and Hispanics have higher rates of diabetes, as expected. And then by gender, females have higher rates of diabetes as opposed to males. So females are at 17.8%, and then males at 11.8%. Looking at it by education, diabetes prevalence by education, diabetes prevalence is higher among persons who did not graduate high school. As education level increases, diabetes prevalence reduces. And then taking a look at it by income, it's a little scattered, but generally speaking, we could say persons who have lower income have higher rates of diabetes. And then by health insurance status, persons who are uninsured has a slightly higher rate of diabetes. So we'll move on to heart attack prevalence. So persons were asked, have they ever been told by a doctor they had a heart attack, or have they ever suffered from a heart attack? Our heart attack prevalence in the USVI is at 2.3% in comparison to the US, which is greater than ours at 3.8%. When we look at it by race and ethnicity, white persons have a higher prevalence of heart attack, and so does females. Heart attack prevalence by education, persons who did not graduate high school had higher prevalence of heart attacks, and then persons who made lower money, had lower incomes, their prevalence were also higher. However, health insurance status didn't seem to make a difference when it came to heart attack. So that could be something with access to care, whether you have insurance or not. We know some of the services are not as readily available on the island as they should be. Looking at hypertension prevalence, in the USVI, our prevalence is at 31.3, which is pretty comparable to the US. We're a little bit lower. By gender, females have higher prevalence, and this is a trend. I don't know if anybody picked up on it, but so far, females have been having higher prevalence. And then looking at it, hypertension by race and ethnicity, persons of other race had the highest prevalence, followed by white people, and then Hispanics and Blacks. Hypertension by education, again, this is a trend that we've been seeing. Persons who did not graduate from high school has higher prevalence of hypertension. And then the income is pretty spread out. Hypertension is pretty prevalent in our community, no matter what income bracket you fall in. And the same for insurance status. Persons who had health insurance actually had higher prevalence of hypertension. Now we'll discuss cholesterol, and I pretty much, there's a lot of data to share, but I just pulled out the main risk factors for chronic diseases that we experience here in the territory. So regarding cholesterol prevalence, our cholesterol prevalence, again, is pretty comparable to the US. It's a little less. By gender, females have more higher prevalence. I wanted to speak a little bit about the cholesterol prevalence by age because I didn't highlight the prevalence for the other diseases by age because we know it worsens with age. People of older age are more predisposed to chronic diseases. However, this is what was one of the most things that was shocking for me because the prevalence of high cholesterol among this age group and this age group, 18 to 24 and 25 to 34, I think that's pretty alarming. And it shows why heart disease is the #1 killer in the territory, right? And then by race and ethnicity, persons of other race had the highest prevalence of cholesterol, high cholesterol. And then again, the income is spread out. And persons who did not graduate high school had the highest prevalence of high cholesterol. And then the last piece of data I'm going to share is the obesity prevalence, because all of the chronic diseases are tied and closely related to obesity prevalence. So our prevalence for obesity is at 35.6%, which is slightly higher than the United States prevalence. By gender, again, females were leading the way, not in a good way. But and then for race, Hispanics have the highest prevalence, followed by blacks for obesity. And obesity, again, is spread out by age. We see the obesity prevalence from 18 to 24, 18.1%, and it just increases to at least until age 54, and then it slightly starts to decrease. So we know that health disparities are related to these chronic conditions, and they are more prominent in people of color. Some of it you just saw in the data. People with disabilities, people living in rural communities, making us all here vulnerable, older adults, people with mental or substance use disorders, people with less than high school education, people with low income and those experiencing poverty, and people who identify as lesbian, gay, bisexual, or transgender. So I'm going to shift gears a little bit and talk about what we do at the Department of Health in the Division of Chronic Disease. Some of our main objectives are to promote wellness, host community health activities, provide educational services and self-management programs for chronic disease prevention, foster collaborations within healthcare systems. We leverage resources, so we bring our partners together, identify gaps, and try to fill those gaps by leveraging our funding, which is always limited. And then we do chronic disease surveillance, such as the behavioral risk factor surveillance system, which is the data I just shared with you. So a lot of our work in our division goes into addressing the modifiable risk factors, which includes tobacco use, poor nutrition, and lack of physical activity. So how does chronic disease tie into all of this health equity stuff? What can we be doing? Some of it we are already doing, some of it we still have work to do and we can improve in. So what we're doing is integrating health equity into our work at every level. So we're building capacity first by training up the staff. We traveled to the Chronic Disease Academy in Chicago. We attended a lot of conferences and a lot of sessions on health equity. Thank you to the Health Disparities Program for providing this training today, which my staff and I are here. We're really happy to be here. And then one of the things is I want to mention we just got a grant for cancer prevention and control to build coalitions, and that health equity is integrated throughout that funding. So in my existing funding, they're trying to tie it in more now, but it's from inception in that funding, and it starts with our work plan. So there's a shift, and Dr. Baumann is laughing. There's a shift from SMART to SMARTY objectives. So we all know the SMART objectives, right? Specific, measurable, achievable, relevant, time-bound. So now we have to shift our objectives to include the I and the E, which stands for inclusive and equitable. And I'm going to give an example of, this is an example of one of our objectives pulled from my cancer work plan. So we have a SMART objective, and then we have a complementary SMARTY objective. The SMART objective focuses on the entire population. So this is one that, as I stated, is pulled from the work plan. So we have by June 2023, We're going to reduce the obesity prevalence in the USVI from 35.6% to 34% by implementing the Eat Healthy, Be Active community workshop. And you see the data. I'm so glad we have the breakfast data, because prior to that, we would have been using 2016 data. So we have new data too. We have our baseline, and we know what we're working towards. Now, the SMARTY objective states by June 2023, reduce the obesity prevalence among African American and Hispanic women in the USVI by 1% by implementing the evidence-based intervention, Eat Healthy, Be Active community workshop, and adapting the materials to be culturally relevant. So anybody sees the difference? Right, we identified our target population, which are Hispanics and Black women. And we use the data, because I've been saying women have higher rates of this, that, right. So I'm using the data to then identify what the target population is for this intervention. And then we had to make sure that we mention that it's going to be adapted to be culturally relevant and sensitive to our population. So another way that we are closing the gap in health equity in chronic disease is through collaborations with our partners, and many of our partners are here, Virgin Islands Partners for Healthy Communities. I work very closely with Karen Hunt and her team. University of the Virgin Islands is another one of our partners. And then Rena Francis, Department of Education. Hi, nice to meet you in person. We had so many team meetings. So we are strategic and inclusive in our partnerships. And then, so we're working within and outside the Department of Health. I collaborate very closely with the Health Disparities Program and the community health workers in that program as well. The community health workers, we did a training for them, so they teach the community on chronic disease self-management. And then we also have to include the community and the target population in our decision making. So that part we have to work on a little bit more. But we also are improving our data collection and analysis to track the progress and measure impact. So those I don't think we're as good as we should be at evaluating our programs. Thank you for Dr. Valmont. That's the strength of that's my evaluator for all of my programs. So that's something that we've been working, and our funders, our grantors are looking more for these evaluation plans and want to see results of our evaluation, and they want us to also write how we're going to include the recommendations from our evaluations into our upcoming and subsequent work plans to measure the impact. Additionally, we are addressing the root causes of chronic diseases that are attributable to the social determinants of health through the use of the community health workers. We're going to be, and we have already started using our community health workers to reconnect. So as a result of COVID, preventive services decrease, screenings decrease. So some people it's going to be to reconnect them to the healthcare system. And for some people, it might be a first time. So a lot of people do not seek care until they show up at the emergency room. So we need to go out into the community and find those people. Why are they not seeking care? How do we prevent them from showing up to the emergency room and using the emergency room as their primary care physician? So some examples of the clinical and social services that the community health workers would be providing the resources for include transportation and housing, education advancement opportunities, employment opportunities, and it could be as simple as people being eligible for SNAP or WIC benefits, not knowing that they're eligible, maybe do not have the educational level to complete the application. That's something a community health worker can assist with. And then lastly, connecting with patients where they live. So going into their communities, their workplaces, the grocery stores, the schools, wherever they are, to increase the utilization of the healthcare resources. And I'll give two examples of programs that we at the Division of Chronic Disease are currently implementing or plan to implement. So one is through the sponsoring community wellness programs. I'll talk about that a little later, and then targeted patient education and culturally adapted interventions. So the first is the NCD Collaborative for Diabetes, and my entire team sitting over there together. I wonder if they're having a meeting. So that's my St. Croix team for the collaborative, and then we have a team on St. Thomas as well. So this collaborative is through funding from the CDC, and it's pretty much a quality improvement process for diabetes management in clinical settings, and it's utilizing the chronic care model, which has a lot of elements that I'll explain. But we have 4 teams in the territory. We went to Puerto Rico about 2 months ago for our kickoff meeting. We have a team at the Frederiksted Healthcare Center, so we're engaging persons or partners outside of Department of Health. A team exists at the St. Thomas Eastern Medical Center, and then we have 2 teams at Department of Health, one at the Community Health Clinic in St. Croix, and the other at the Community Health Clinic in St. Thomas. The mission is to improve the health system. So we want to create an organization that provides safe, comprehensive, and high-quality care. Then we also provide self-management supports, where we are empowering patients to manage their health care. So that's where we offer our self-management programs. We identify patients within these clinics who have uncontrolled and unmanaged diabetes. Each clinic identified 50 patients. We are providing them with education through our self-management programs. We have our chronic disease self-management program and our diabetes self-management program. And throughout those 6 weeks, they are learning ways to manage their diabetes. And we are utilizing our community health workers and the chronic disease staff to teach those classes. And then we want to improve the delivery system design. Again, we have the healthcare teams. So each team has about 3 to 5 persons that have distinct roles. Each team has a data manager, a nurse educator. We have a physician champion. Dr. Dizan is the physician champion for St. Croix. And Lisa is the nurse. Janesta is the diabetes educator. And then Lenisha is just support and nurse support. So each team has members with distinct roles, and they meet regularly. They identify their objectives based on what their population look like. So one of the things that they notice is that persons who have diabetes, not all of them had current A1Cs. So that was one of the first tasks. Pulling the files and then trying to get current A1Cs for those persons who have unmanaged diabetes. Then we're also utilizing decision support, so integrating the evidence-based guidelines. The guideline states that persons that have diabetes should have A1Cs 3 months apart. So we're utilizing those guidelines and integrating it into the clinic flow. And then we have the clinical information system, so we're tracking and monitoring, utilizing data to guide the decision making. And then lastly, we're partnering with members from the community. So one of our partners for this program is the Virgin Islands Diabetes Centers of Excellence. So we are pulling in our partners to fill gaps that we may not be able to address in the Department of Health. Another one of our programs is the Health Empowerment Program, and that one was a true collaboration with Department of Health, UVI CERC. So we were the sponsoring agency. UVI CERC implemented the program through Dr. Michael and her team, and then the Virgin Islands Housing Authority, they provided the setting. So we went to their housing communities, and they were the host site for the implementation of this intervention. The intervention was focused on cardiovascular and cerebrovascular risk reduction, and it took place over the course of 9 weeks. Some of the program activities included education, of course, and management and prevention of cardiovascular disease and stroke. Participants were encouraged to set goals to manage their own chronic diseases. We did blood pressure and cholesterol monitoring. We provided cooking demonstrations, physical activity opportunities, and they also had lessons on how to farm and grow their own fruits and vegetables. So I'm just going to read one of the testimonials from one of our participants who suffered a stroke and was a participant of the Health Empowerment Program. She stated, "My goal was to lose 5 inches from my waist. I did that. My cholesterol was 247. Yesterday when I checked, my cholesterol was 202. So we know that these types of programs work. And we don't have the resources to touch everyone, but we just have to do more of this, leverage our resources. At the Department of Health, we may not have all of the resources, but that's where our partners come in. So I'm just going to leave you. I'm coming to the end of my presentation, and I want you to reflect on some of the protective factors or the luxuries that contribute to your ability to successfully manage your health. So spend a couple, and you could discuss it, 30 seconds, some of your luxuries that you may take for granted, but these luxuries allow you to successfully manage your health. Y'all thinking? Okay, so I will share mine, and then you could add if you have something to add that I did not share. So for me, my main one is a secure job and income. Health insurance, paid time off to go to the doctor, having a working car to drive to the doctor, the ability to understand and act upon instructions from a clinician, having spare cash to pay for a prescription, an MRI, or a follow-up, having stable housing, and having good family support. So those are some of my luxuries that allow me to obtain and maintain health. Anybody wants to add anything? Knowledge. Nothing. Oh, wow, how lucky her gene pool. She come from good stock. Right, genetics, and that does play a role. So what I want you to just think about and what I want to leave you with, so some of these luxuries, the people who we are trying to reach, they do not have most of these luxuries. So when you go to them in the community, when you're working with them, remember to be empathetic, humility, compassion, love, affection, because they have a lot going on in their personal life that we take for granted. So that concludes my presentation. These are my references. And I have to acknowledge John Orr. He may be on Facebook watching, but that's my data guy who could not be here today, but he provided me with all of the data that I presented to you. And he is forming a data users group, and he's looking for persons to be a member of that group. So if you have a love for data, you desire more data, you want to contribute to the body of data, whatever we have, please reach out to him. He will be happy to have you. He loves what he does, and he explains everything. He over-explains, but yes. But he's awesome. And that ends my presentation, and I see Dr. A.C. Malloy have a question. Sure. Yes, I will send Koya, she's been my point of contact, a copy of the presentation. Okay.
Thank you, Dr. Fredericks, for excellent presentation. I was raising my hand to be the #1 volunteer to join Mr. Orr, yeah. But I wanted to point out something that, the power of data. Could you go back to the diabetes slide? Not the diabetes, the obesity, sorry. So the chart in the lower right-hand corner, it shows that obesity at its highest level at 45 to 54, and then all of a sudden it drops off. Why do you think it drops off? Remember the respondents to this are individuals who are capable of responding. I'll just leave you with that question.
Good point. Right, and the data is just what it is. These are the numbers. These are what the respondents say. We have a lot, I mean, we could speak historically speaking, anecdotally speaking, but if you really want to know more about the data, it would require additional research. I don't think the participants, one second.
Yes, what I was saying is that what alarms me even more is at the other end of the spectrum, the 18-year-olds. That, to me, is extremely alarming.
I agree. And we know childhood obesity is a problem globally and here locally as well. So we definitely have to address from childhood, and we are working with the Department of Education and the Maternal Child Health Program to implement. Our intention is to implement some sort of intervention that reduces obesity and overweight in children. But that's what we're working towards.
No, I was just saying because you could get 50 nuggets for like 25 cents. So, you know, it kind of starts with, yeah, breaking away from that.
I want to thank Department of Education because this is one of the first times that we've actually seen education deeply involved in health processes. I remember working at UVI and being at so many meetings, and one of the entities that I thought was always needed was education. So to the group that's here, thank you, because you cannot speak about equity, you cannot speak about decreasing chronic disease if you don't speak about children.
Thank you.
Thank you, Dr. Fredericks. Again, amazing information, and data-driven decision-making is one of the priorities for the Department of Health in our strategic plan and our Healthy Virgin Islands 2030. So it's really important that we put our money where our mouth is, you know, that we say we're going to do something and we get to work, but again, the importance of the partners. So our next presenter is Miss, make sure I say your name correctly, Julicia Thomas, and she's the coordinator for the Behavioral Health Division at the Department of Health. So while we get set up, I just, you know, you saw Linnea started with reflections, ended with reflections. And I really appreciate that opportunity that, you know, we get a lot of information. Karen talked about the importance of knowledge, right? And it's important that we do take time to digest a little bit, see what that information means to us, how we can use it, and when we leave here today, what actionable items we can do to help us improve not just our knowledge and understanding of health equity, but also how we can continue to partner with everyone in the room and in our viewing audience who is encouraged by what we're doing here and what you're hearing today to be even more involved than you already are. So, Ms. Thomas, there you go.
Good morning, everyone. It's really nice to be here. I'm stepping in for Mr. Steele today. So, you know, teamwork is, you know, we're together over here in the behavioral health units. So today I will be discussing the behavioral health equities. Again, my name is Julicia Thomas. I am the territorial coordinator for the behavioral health units. And I'm a little nervous, but we're gonna get through this together. Okay, so today we will be discussing what is behavioral health. We have some stats and what are we doing at the behavioral health unit and how to contact us. So what is behavioral health? Behavioral health refers to how our daily cognitive habits affect our overall well-being, emotions, biology, and behavior. It's often used interchangeable with mental health, but it's actually a far more expansive term that incorporates not just our mental wellness, but the way our thoughts play out in our real life. So our treatment spectrum, so it starts mild, of course, with the personal therapy. So you have 1 to 4 times per month, family therapy, individual therapy, play therapy, and school counseling. Then you can move on to the outpatient programs if needed, which is the intensive outpatient day treatment program, which can last 6 to 12 weeks. Those that may be experiencing anxiety, bullying, depression, school avoidance, social struggles, suicidal thoughts, all of that. That is what the outpatient program has. And then we have the partial hospitalization, which is 3 to 5 weeks if needed. And then we transition to the hospitalization. If needed, which is 3 to 5 days. So we go on to behavioral health disparities. So behavioral health disparities refer to differences in outcomes and access to services related to mental health as substance misuse, which are experienced by groups based on their social, ethnic, and economic status. So when we look at the stats, we see in the past year serious mental illness. So among adults age 18 or older in the United States by gender, race, ethnicity, and age group. So we see females are more likely to report serious mental illnesses. We have American Indians, 6.7%. We have the white population, 5.7%, and of course the black population, 4.0%. Then we have the age group, 18 to 25 are more likely to report serious mental health illnesses in the United States. So in the past years, we've seen dramatic rise in opioid-related deaths, especially among blacks. So the drug overdose deaths involving synthetic opioids other than methadone per 100,000 population by ethnicity. So we have seen the 18-fold increase in mortality in the non-Hispanic black population. And then we've seen a 12-fold increase in mortality in the Hispanic population. And the non-Hispanic whites, we have the 9-fold increase in mortality. Some saw racial ethnic differences in mental health service use. So in outpatient mental health service, use in the past year was highest for adults reporting 2 or more races, and white adults. Black adult use landed at 4.7%. However, in the same time frame, inpatient mental health service use was not prevalent among black adults. Service costs or lack of insurance coverage was the most frequently cited reason for not using mental health services across all racial and ethnic groups. The belief that use of mental health services would not help was the least frequently cited reason for not using mental health services across all racial and ethnic groups. So basically, we're lacking with insurance. In the black community, a lot of individuals do not have insurance to see someone, but it's not that they don't want to see someone. So mental health services used in the past, so within 2008 to 2012, the people that are using mental health services. So again, you see mostly females seeking help. Why is that? Usually because of the stigma. I have a friend who is a guy and has been suffering from mental health illnesses. And when I ask him, why are you not seeking help? His answer is always, well, I'll look weak. So the guys always think that seeking help makes them look weak. No woman would want to date me, which is not true. It's the complete opposite. So that I've seen that across the board. Working in a behavioral health unit, a lot of the males do not want to seek help as much as the females. But it is increasing. So here we have, in the white population, you see a lot of females in the white population seeking help using the mental health services frequently. Then you have a high rate in 2 or more races as well, seeking help as well. And of course, you see a drop in the black population and the Hispanic population and also the Asian population. So when we go by age group on the other side over here, we have mostly those 35 to 49 using mental health services in the United States. So what does this look like in the Virgin Islands? In 2020, the U.S. Virgin Islands population was 87,146. Black or African Americans, 62,183. Multiracial, 32,000. White, 11,584. Hispanic, 16,075. And then we have males, 42,343. Females, 44,803. So of the 3,494 Virgin Islanders 18 years or older, approximately 1,742 experienced serious mental illness in the last year. So we should have seen 2,912 women in our clinics, which we did not see. 3,708 adults from 18 to 44 should have visited our clinics, and 2,923 residents identifying as Black or African American should have been seen in our clinics. So why aren't we seeing the numbers? Again, cultural stigma, lack of trust. The island is small. They're not very trusting. Everybody knows someone. My business is going to get out there. I'm going to speak to someone, and they're going to tell their family members, and they're going to think I'm crazy. These are the things that we hear. Lack of awareness. A lot of people don't know the services that are out there, so they're not going to seek the services. Hours of availability. A lot of mothers we hear, I don't have time for that. I am with my child. After school, I have to pick them up. I'm a single mother. I don't have time to visit anyone and talk to anyone. I'm not going nowhere. We hear things like that. Lack of staff and providers. And also, again, insurance. Some people do not have insurance to seek the help that they want. So establishing behavioral health equity. So what are we doing? We're going to go, what we've been doing, community education. We're revamping the whole outreach team. So I am a new member of the behavioral health unit, and as the coordinator, we have some community outreach workers as well that we work alongside, and we're trying to get that information out there. We're going to the schools. We visited Juanita Garden so far, the complex. We're trying to do low-income communities. We've been to Harvey View and all these places. We're trying to get the message out there. We're trying to have a new outlook on how everyone sees the behavioral health services. We're expanding community partnerships. We have an event coming up with the West Care, the village, to do an event for those in school as well. So just expanding partnerships, finding people that, going out there, finding new partners, finding out how we can work together. Reconstructing the behavioral health bill, and mobile services for high-risk populations. So we have the vans, so now we have to get the vans on the road, get them out in the community, have them parked up, have awareness. Yeah, you can come to the vans whenever you need something, you need help, we're here. So these are things that we're doing now. So we want to also leave a little quote. Your present circumstances don't determine where you go. They merely determine where you start. So this is a big quote that we use here at the Behavioral Health Division. What is currently offered? So right now we have intensive case management, individual therapy, medication management, outpatient groups, such as the clubhouse. We have the treatment team, we have the outreach community service, we have local and off-island residential services. We have the opioid overdose prevention team, narcotics and alcohol counseling. These are things that we offer here at the behavioral health units. Again, where are we trying to go? So we want to have the 988 crisis center, 24/7 crisis call. You can call in if you have any type of behavioral mental health need. Someone is going to be there to answer and serve you as best as possible. We want the community-based mobile crisis services, which again, we have the vans, we have to just get them out there. The workforce development, residential psychiatric facility. And in a world where you can be anything, we want you to be kind. This is another saying that we want to leave you guys with today. It doesn't cost to be kind. You can always just be kind to someone. You don't know how you can change your day. And we just I want to thank you guys for having me here today. Special recognition to the Division of Behavioral Health. And your creative and innovative thinking has put us in a class all on our own. No one else can compare. And this is our contact information if you need to reach us on the St. Thomas, St. Croix District, and on the St. Croix District. And that is the end of my presentation.
Excellent. Didn't you do a wonderful job filling in at the very last minute for Deputy Commissioner Steele? And appreciate your information that you've shared, how you shared it. As you got more comfortable, you just were able to talk it out, and that's So that's where we're headed today, okay? So we're starting, open up with some wonderful remarks, and I see Dr. Ellis's hand up. You had a question for Ms. Thomas or a comment? Okay, hold on, somebody bring your mic. But while we get going for the rest of the day, I anticipate this is going to happen more and more.
Thank you. Excellent presentation. Really good job. And you only get better as you do it more. So what has been on my mind a lot is the opioid crisis and how do we identify at-risk individuals here in the territory, because we don't have good comprehensive pharmacy data. So here, potentially, a person could go to multiple pharmacies to get the same medication and it wouldn't be detected. So what are you guys doing, or what's kind of a brainstorm idea to help find at-risk individuals to get them into care?
Okay, good question. So we have the opioid prevention coordinator who just came on board not too long ago as well. I know that he sees patients and he's doing a whole new intake process and working with the pharmacies and so forth. So that's a good question for him, and I can definitely get you that answer. So you can contact us and we can discuss what his plan is or what he's doing for that process.
I commented to my chief of staff, Shana, just a little bit ago that one of the, and maybe they're here and I just don't see them, is someone from the hospitals, because data is entered every time someone comes into the emergency room. A code is put in, and from that code you can actually determine what the diagnosis or the admission or the visit diagnosis is. We can pull that information. So that's one of our partners that we work, and I know, Dr. Ellis, you asked that question, but I know you work very closely with the hospitals getting that data on an ongoing basis. So it's good for everyone to know. So we will be partnering with the hospitals as well as with the pharmacies. We are thankful. We have not seen many deaths. I think 2 years ago we had 2 deaths related to opioid. And that was in a specific segment of St. Croix. And VIPD, Department of Health, we got in it real clearly, and we were able to stop further distribution of what was causing the morbidity and ended up with 2 mortalities due to overdose. So those are the things that we're doing. What we have to do, like we say, and it's not just Department of Health, but it takes a village to prevent the opioid crisis that is being seen throughout the nation.
Thank you. I inherited the second. Another question?
Good morning, everyone. Not a question, more so a suggestion and listening. Thank you so much for your presentation. And it's based more for our own gaps that we have within the U.S. Virgin Islands as minorities. One of the areas that could help also with your gatekeepers is within our local Black and Brown Hispanic communities to partner with some of our gatekeepers within our organizations. An example would be that December is one of our main opening for the community organizations for our celebrations, right? For our carnival celebrations. We could partner up as well with the organizations and those gatekeepers so that inside of the celebrations, DOH, and we can coordinate with DOH and different other organizations to come in and also use that as outreach. Therefore, there's a bigger spread, a bigger reach inside of the community that needs the support as well, and that helps to connect the gaps instead of also going into the communities that need it. For the vulnerable populations who were able to go inside of the events and directly go inside of the communities that need the support and the help.
Thank you. Yes, thank you for that.
Okay, thank you. So you saw me passing a note. That was just Issy Malloy making sure that he gets a copy of the presentation. But I believe we'll be sharing those with everyone. So thank you for that. So please, a round of applause for Ms. Thomas. And our next speaker, moving right along, is, of course, Mr. Graham, who so kindly did our presentation for us. Are you going to come up front, or? I believe for the live stream, we need, I'm getting all kinds of instructions, so hold on, everyone. While we do that, commissioners asked for us to kind of, again, kind of move a little bit, so let's, she asked for a wiggle. So while in your chair, just wiggle. So on behalf of the Disparities group, Mr. Bruce Graham is the manager at the Christian State Lighthouse Mission. He shows his devotion to aiding people by providing a meal to the less fortunate. Mr. Graham is a graduate of Oakwood University in Huntsville, Alabama, with a Bachelor of Arts degree in theology and a Master of Arts in education, counseling, and guidance. Welcome to the podium, Mr. Bruce Graham.
So very much. Thank you, thank you.
No big, I feel like pop.
Come on.
Shot. I'm coming in hot.
Come on.
Yeah, coming in hot. Just like the fajita. I write what I live. My life in the speaker. I'm nice with the flow. Just like the demeanor. I'm feeding my fam. I'm feeding the meter. They got the iron while I got the steamer. I bring the fire, but you never seen them. I testify, I don't need a subpoena. They want my soul way to go to Korea. I love my dog just like I'm Peter. Gotta protect him. I made the call up with just like I'm rapping. I know we left, yeah, now we back together, but I guess that is better now. Later than never, like, what's happening? I'ma need y'all to quit asking when. Me and my wife gonna have some kids. Right now we just practicing. Practicing. Teacher said quit rapping, man. That gonna hurt my average. I said, thank God I ain't average. Yeah, I'm a bright young man. Get a GPA and a BPM. Look, we on. So say what you say, cause that's A with Lil' Craig. From the A train to the A. I'm coming in hot. I don't do the most, but I do a lot. I'ma make a toast, cause we still alive. No big, I feel like pop. I shoot a shot. I'm coming in.
Thank you for that.
Oh boy. That was wild. That was wild. That was crazy. To God be the glory. You know, I want for you to realize that we are here today, and so we ought to take every advantage of why we're here. And you may not felt like being here today, but I want you to just live in the moment, enjoy the moment. Please repeat after me. I'm alive. I'm not dead. Thank you, God, for my daily bread. I'm alive. I'm awake. I really wish they had some Johnny cake. To God be the glory. I bless the Lord for today. Today, we're going to talk about something that it is dear to every one of us. Whether we think it or not, it is dear to every one of us. We are individuals who need in our lives the power of spirituality. The power of spirituality. Now, I want you to realize that spirituality, it is the way you find meaning, hope, comfort, and inner peace. Many people find their spirituality in religion. There are those who find spirituality in dance, music, also in nature, in the arts, and there are just a few who find their spirituality in the expression of their values and also their values and their principles. Now, if you go on the internet, you look for dimensions of health, and you will see a varied amount of dimensions, varying from 5 to 12. However, I would like to suggest, or like to say, that there are 5 main principles of health, or rather 5 main dimensions of health. We find that we have the physical, we have the emotional, we have the social, we have the social and the spiritual, and finally we have the financial. Now, understand that all these dimensions work together in concert. These dimensions of health are vital to the individual, or to all of us. We have the physical, the emotional, the social, the spiritual, the physical, the emotional, the social, and the financial. But all of these are encapsulated or encased in the spiritual. You may not really think that way, because when you think of spirituality, all you're thinking about all those God people. You know, but spirituality is deeper. Of course, it entails something to do with a higher power, but it is what makes us up as human beings. So human beings, we are multifaceted. There is what you call a triangle, where we find the body, the mind, and the spirit. All are a part of who we are. They make up a part of who we are. Body, mind, and spirit. Think about it. Think about it. Now, if the body is affected, the mind and the spirit will be affected. If the mind is affected, the body and the spirit will be affected. When we have the spirit affected, the body and the mind is also affected. And so therefore, it is important for us to understand how to get our entire being together. We must find some connection, keep the connection between all three. Body, mind, and spirit. We cannot say that my body feels good and so my mind can go any which way it wants to go. No, the mind helps to keep the body feeling good. And the body, when the body is good, the body is healthy, it helps to keep the mind. And then deep down within our consciousness, our spirit. You know how some people say that my spirit don't take him. I don't know. I don't know why you want to take him. Lord have mercy. But I want you to understand that body and mind and spirit, we must get all three working together. I want for us to know that each is impacted by the other. So many of life's events brings immense challenges. And if you do not know how to cope, if an individual does not know how to cope, it will leave him or her broken or shattered, or even both, broken and shattered. There are some stuff, I tell you, that comes to our lives. Some stuff that came when we were 2 years old and when we were 11 years old. There was some stuff that came to our lives, and those stuff, although we are 28 years old and 48 years old. Why am I sticking with the 8? Let's go to 45. There's some stuff. There's some stuff that comes to our lives, and they get at us, and they eat at us, and they beat us up. And if we are not careful, they will cause us to either implode or explode. And when we implode, we are there like a shell, and we are in a corner all depressed. We've seen this in our community, and you might have experienced it yourselves. But I want you to understand that we need to find ways of coping. And when an individual explode, I say, good morning. Why? You saying good morning? How happened to you? And if we are not careful, it will cause us to break down. I've been looking at the statistics for mental health. Let me tell you something, that if you want to stay whole mentally, you've got to make sure that your body, your mind, and your spirit are ticking together. Ticking, I can't even talk about ticking because we don't wear those ticking clocks anymore. We have these digital stuff. And so we have to get it together. And so in life, you are primed with doubts and disbelief. Negativity, you were born with negativity. None of us were born with positivity. You see, we were born with negativity because all we hear on the news and all we hear mommy talking about, when she talk about the neighbor, she talk about the neighbor, so nasty, Lord have mercy. All we hear is just the negative stuff. Boy, Bruce, you not go to school? You're going to be a garbage man when you grow up. I used to hear that. And I want for you to understand that we were born primed to disbelief and doubt. And we have got to come to a place where we find in our lives a spirituality. Spirituality can help bring meaning to your life. You ask yourself, why do I exist? And you keep pressing yourself, why am I here? Am I just here to sit on the corner and psst, are the girls then passing by? No. I want for you to understand, am I here so that I can go into the neighborhood and make trouble with those in the neighborhood and sell the little thing under the table? Am I here for that? Why am I here? Why are you here? We must ask ourselves, why? Why are we here? You see, spirituality helps us to find purpose for our existence. And when we find purpose for our existence, it can bolster our positivity and our productivity. purpose makes us productive. So if you find yourself being at your desk there in the Department of Health and Commissioner Encarnacion is not nearby and you're just there playing games on your phone, think about your purpose. Your purpose. Why do I exist? Do I exist simply to earn money and then spend money? Is that all that I'm here for? You know, when we think about purpose, purpose keeps us moving. Purpose keeps us going. Purpose keeps us standing. Purpose, it is vital for our lives. In life, you come, as I've said, you've come primed with doubts and fear, doubts and disbelief. If you hang out with chickens, you're going to cluck. And when you hang out with eagles, you're going to soar. Many of us have heard many of this when we were in high school, and we've heard these sayings before, but I want for us to get it in our heads. As they used to tell me, get it in your thick skull. But hey, this is not the moment to say these negative. We want to keep it positive. And so it is important that we recognize that when we sit down and we talk about what Brian Roach na do and how them thief the money and what Commissioner Encarnacion, I mean, me don't know what she do their Department of Health, no. But I want you to understand, instead of our just focusing on the negative, we ought to look to the positive. We ought to look to where we can find hope. We can look to where things can and will get better. The power of spirituality. The power of spirituality. When everything in all around you is falling apart, you can hold on with hope. You see, when the trials and the testing of times, because they are going to come. There are going to be some hard times in your personal life. There are going to be some hard times in your work life. There are going to be some troublesome time because your children, those knucklehead little picnic them now go do nothing with themselves. Yeah, I want you to understand that things are going to get difficult and rough. You mean to say I'm going to raise up my picnic them for go to church and I'm send them to church school and look on my little boy. I just say that one because but you mean to say I brought up my son and my daughter and they are getting into all this mess? And that hurts. It hurts you as a parent, and it makes you question whether you did your job as a parent. It makes you question, did I model before them the things that they should have seen? And so here in this world, we can find hope. Hope. Spirituality helps us to find hope. Hope will bring you comfort, and with comfort comes inner peace. Hope is that belief that even when things are going wrong, they can and will get better. Even when I've fallen on hard times, there is a moment in life that things will change. Hope will bring you comfort, and with comfort comes inner peace. When our minds are disturbed and trouble, then we cause trouble in the community. We cause trouble in our household. We cause trouble for others who are not even causing trouble. because our minds are disturbed and troubled, and we have got to find ways of coping. And I submit to you that spirituality helps you to cope with the troubles of time. There's a song we sing in church, troublesome times are here, driving men with fear. And I want you to understand, we are fearful of what is happening around us. But I tell you, in order to alleviate fear, we can find hope in our spirituality. Whether your spirituality entails dance, music, the art, your principles and values, or nature, you must find an avenue that will lead you to positivity, that would lead you to making a better household for your family and making you a better father so you're not a deadbeat father, and make you a better citizen of the Virgin Islands community, a better citizen of the St. Croix community. I purposely said it St. Croix. The St. Croix community, or community, it may be the same. It may be the same. But we ought to make things better, not only for us and our families. We ought not to simply look out for numero uno. Did I say it right? We ought to look out for todo mundos. I was supposed to put an S at todos mundos? No, yeah. But bless the Lord. I want you to understand that we ought to find inner peace in our spirituality. Note, I didn't say religion, because religion, and you can find spirituality in your religion, but there are other things you can find spirituality. It was the Reverend Jesse Jackson who always say, keep hope alive. Yes, hope, always believing that things are getting better, even though it seems even though everything is topsy-turvy. We're Virgin Islands. We don't use that word, but topsy-turvy. Even though things are not going very well, our spirituality helps us to believe that things will get better, that things are getting better. Things don't get better in an instant. Life is not like McDonald's, where you can order a better life with a side of happiness and an extra large cup of $1 million. Life is not like that, where everything comes to us at an instant. You've got to believe in the possibility and grind daily. We think that we can be happy. We think that we can be joyful. We think that we can be at peace, and we must just sit there and do nothing. We've got to keep moving. We've got to keep our minds moving. We've got to keep lifting up ourselves and not settle for lifting up ourselves. We've got to keep lifting up our children. We've got to keep lifting up our families, and we lift up our communities. Get involved. Do something to your community. There's one thing that I always that I care about, and I haven't done a thing about it as yet. And I should, because this is a passion of mine. And that is, I believe that we live in one of the most beautiful places in the world, one of the most beautiful, and it is the United States Virgin Islands. I think they say that the Virgin lost her. Oh no, but I want for us to understand. So now they call it the American Paradise. I want you to understand, if we want to keep it the American paradise, we've got to take care of our environment. And one of the things that I'm passionate about, and I need to get going with it, It is that rather than having the Boy Scout or whoever it is, their different groups, establishing a recycling program and setting up at the market, and you drop off your recycling, and there was a program there, I don't know if they're still there, right there in Anna's Hope by Public Works. Rather than doing that we have recycling bins where we recycle cardboard, cans, bottles, plastic. If we can get that going here in the Virgin Islands, we ought to care about our environment. We ought to love our environment. We ought to love this here or these here Virgin Islands, this here St. Croix. When my children were growing up, I often told them, never let me catch you littering. Never let me catch you throwing things on the side of the street or anywhere in the community. As a matter of fact, I took them. No, they're big man and big woman. They're not bothered with the old puppy, you know. And so now I want you to understand that I took them and I showed them this. We ought to take care of the place that we live, because we definitely don't do the number one and the number two in the same place that we sleep. And so, purpose. We ought to take care of our environment, take care of what we believe in. Spirituality is a part of taking care of the Virgin Islands. Okay? We're not just taking care of the Virgin Islands for tourists when they come to the Virgin Islands. We're taking care of the Virgin Islands because Libya. I'm eager to take care of them because for me too. It belonged to me too. And so over time, people think that things will get better in an instant, but over time things do change. Over time, people understand that it takes 3 to 5 years for a coconut tree to grow up before it starts producing coconut. But yet still, we cannot fathom that it takes time for changes to take place. It takes time. And as long as we are grinding, as long as we are pushing, as long as we have positivity, as long as we have hope, things are getting better. Your eyes may not see it, but things are getting better. It was Barack Obama in his Audacity of Hope speech who said, "Yes, I can. I believe that we stand on the crossroads of history. We can make the right choices and meet the challenges that face us, America. Yes, we can." You can take the sentiments of this political speech and tweak it to your spirituality. In the face of life's challenges, hope gives you the courage to stand with your head up high, even though the pain is digging at you, your emotions, you are hurt because your husband gone left you for some African woman. I hope no African woman is here. But I want you to understand that the emotion is going to hurt you. It's going to pain you. But what you can do is keep hope alive. This person that you knew, this man, he was special to you. You did so many wonderful things together. You had 10 children together. Oh Lord, that's a lot. 2 children together. I want you to understand that even though it hurts, recognize that you didn't do the hurting and you are hurt. So therefore, you've got to believe that I can work through the pain with my spirituality. Things can get better. Things will get better. And in the face of the challenges, I want you to understand that hope gives you the courage to stand with your head up high, and you believe that this too shall pass. It shall pass. When you take the good with the bad, the bitter with the sweet, you can live comfortably in the mind, in your mind, in the midst of the storm. I don't know how many of you, I'm giving away my age, but I don't know how many of you remember Hurricane Hugo. I was right there in Harborview, and when Hugo came through, I don't know who Hugo was looking for, but he turned up everything, and nobody was able to hide under anything. And so I was living there in Harborview, and right there in Harborview, windows start flying out about 5 o'clock, and they just rush, flying all over the place, and fear starts up in my heart. And so as the night move on, it's everywhere, things start making us rock-a-dow, pop, you know, and so it was fearful. And the wind blew against the apartment. And back then they had those louvers, aluminum louvers, and it covered the entire wall. It covered the entire wall. And one of the window in our apartment began pushing in. And when we saw that, my mom, my younger brother, Ulrich, and my niece, Kissa, and my nephew, we ran into the bathroom. And there in the bathroom, we began to sing religious songs. And we began to repeat the Psalms and all that we can think about. And we began to pray. We sang and we prayed and we repeated scriptures. Oh, we did that over and over and over until the next thing that I knew was that it was morning. We fell asleep. We fell asleep in the midst of the storm. And so I want you to understand, although the winds are tossing round about you and things are getting rough, or things are already rough, they are not getting rough, they are already rough, you can find peace in the midst of your storms. Peace in the midst of your storm. Spirituality keeps your thoughts operating on a higher plane. Not in the what if this happened and what if that happened. And suppose that you're believing that things are getting better. And so whether you find your spirituality in dance, music, arts, or in your values, whether you find your spirituality in nature, whether you find spirituality in religion, I want you to understand that if you keep working and pushing to improve and to lift yourself up and to lift your family up and to lift your community up, you will be 100%. Everything may not be 100%, but you will be 100%. My spirituality is expressed in religion. My religion. I am a Christian. I believe that I am placed here upon this earth for a purpose. And I hope that you have a purpose. I hope that if you didn't, and if you never really thought about it, and you're working and so forth, your purpose is not just simply to make people, well, that's not simple. So it's not simple to make people healthy. Your purpose is not just, you believe that your purpose is a high calling. And so you're going to work on that. And so when you see your purpose, my purpose here on earth is to encourage individuals to rise higher and higher. And I'm here to tell you, keep pushing through the pain and the sadness. My spirituality brings me hope, comfort, and inner peace. You see, I will lift up my eyes unto the hills. From whence cometh my help? I'm not looking to Blue Mountain. I'm not looking to Mount Eagle. I am looking up higher. I'm looking way beyond. And when you look up high, you see the blue skies. You see the white as it's painted there within the sky. You see the green as it is, the trees as they're tall upon the mountain. And the wind as it blows against the trees, how it moves gently and sometimes even violently. But I'm looking even beyond that. For in looking up, we see something better than looking down. And all we see is the gutter. All we see is trouble. All we see is pain. But if we look up, we see what can make us much more happy. We see that we can find joy in our lives. So I lift up my eyes unto the hills, from whence cometh my help. Oh yes, my help cometh from the Lord. He is the one who made heaven and earth. I want you to understand that the one I look to, he is the creator. He is the one that formed me out of the dust of the ground. He is the one that shaped me. He is the one that gave me a mind after his own, a mind of positivity. I want you to understand that God has set every one of us up here on this earth to be individuals who are able to bring forth and to be productive in our community, in our families. And so therefore, I know for sure that my help cometh from the Lord. The Lord, he will not suffer my foot to be moved. He will not allow me to be shaken. Yes, things may come and things may be hard, but he will not suffer my foot to be moved. And as I close, I say to you, I challenge you, let your spirituality keep you positive. I say to you, I challenge you to stand up. I challenge you to stay up. I challenge you to keep on climbing higher and higher. I challenge you to remain healthy spiritually. I challenge you to let your spirituality work for you. Keep on grinding, keep on pushing, keep on moving, and don't stop. Let your spirituality work for you.
Thank you so much. Hello, can you hear me? No, it's on. Okay. Thank you again. So while I'm sitting there, and folks, thank you everyone for your continued participation. For those of you watching with us virtually, we are going to continue with the program for right now. We do have a wellness break with our partners from the Cultured Neutrals making body butter. But before we do that, I just really want to kind of reflect on and thank the team that put this together. Healthy Me. We looked at physical, we looked at behavioral, mental, and we looked at the spiritual health. So I really just want to commend the team and give them a round of applause for actually thinking about very intentionally about Healthy Me and what it takes to be healthy in the Virgin Islands and wherever we go. So right now, I believe I turn it over to Cultured Neutrals? Naturals, there you go. Thank you everyone. And again, feel free to move, feel free to get up, move around, and you're in great hands.
Let me just say thank you so much, Commissioner. Thank you so very much. Thank you to the Deputy Commissioner. Thank you so very much. And thank you for the Program Director. Thank you for having me here. Bless the Lord.
Thank you.
Pleasant good afternoon, everyone. What an awesome presentation, Mr. Graham. My name is Ramon Reed Ventura, and I'm the owner of Cultured Naturals Body Care. I have a green beauty and wellness business located here in St. Croix, and we create aromatherapeutic products with topical benefits as well for the face, hair, skin, and home. I'm a nurse by profession that shimmied on over into the beauty and wellness space. So I've had the pleasure to interface with my community even more. And from there, I've been able to stand in a wellness space, assisting persons to incorporate our products into their wellness regimen. What we're gonna be doing today is our body butters, which involves using aromatherapeutic oils. With aromatherapy, it's something that people often overlook. It could be something as simple as having a bush tea in the morning where you smell your lemongrass that actually lifts your mood. What aromatherapy does is when those scent particles go into the nose, it goes deep into the brain and the limbic system, and that instantaneously impacts your behavior, your mood. So if you're in a bad mood, slip on into the, your secret place at work at DOH and take a sniff of your lemongrass oil or your peppermint. Working as a nurse in the ER, I used to have some tough days, and that's what I used to do. Walk around with my aromatherapeutic essential oils in my pocket, slip into the lunchroom, take a big sniff, borderline looking like I'm doing drugs. I had to sometimes tell my colleagues, no, it's essential oils, and take a big whiff of it. And there is science to back this, that our very essential oils do help to uplift you, sedate you, and help you to really have a better day. So we have some great products there located. They're all vegan, natural, and we work a lot with our local farmers to make sure that we give you high quality products. So thank you so much for the invitation, Department of Health and the Health Disparity Program. I'm seeing where you are definitely touching your community holistically, body, mind, and spirit. Thank you for having me.
Okay, thank you. So please welcome Miss Augustus.
Good morning, everyone. This is not my usual place, so have some grace for me. I like to be behind the scenes. So good morning, everybody, and I want to hear you say good morning back since we've been invigorated with some nice essential oils to refresh our minds and our bodies. This is very good wellness. So good morning, everybody. Good morning. Okay. I am the Family Care Manager at the Charles Howard site for the Virgin Islands Partners for Healthy Communities, VIPHC. My focus here today is to speak on what we do as a nonprofit to help families in our community. As it stands right now, I have and do the clinical, administrative, case management, and outreach work for this site. Explanations can get wordy, so I figured I would make it interesting by taking you on a journey, starting with a story of a lovely lady. We will call her Miss Apple B. And I am thankful for permission to share this story. Before I begin the story, however, I will let you know that VIPHC is a locally funded nonprofit that is designed to provide persons in the community with health, healthy lifestyle, and wellness education. We provide family-centered care management, referrals, support, and assistance to access healthcare and needed services that may pose barriers to accessing care. Through collaboration with our agencies, our Promoting Healthy Families initiative works to engage, empower, inform, and support persons in the community who are mainly indigent or with many health disparities. We assist them to arrive at a place of improved health with access to care, a medical home, and increased health equity. How we came to work with Apple and her family. Well, VIPHC receives clients in various ways. Mainly, we would receive referrals for clients in need of our services from community and government agencies, from the Wang Lui Hospital, or anyone in the community. Clients are also encouraged to refer their friends and family members if there is a need, and we do community outreach as well. At the Charles Howard site, we collaborate with just about all the departments for the purpose of service provision and receiving referrals to aid persons in the community. Someone may come in for WIC or behavioral health services or to the community health clinic or family planning clinics, and then it becomes clear that they may need further support, that they may be in need of our services, and so they can get referred by that department to our program, particularly when other matters seem to be posing issues to them being able to address their healthcare needs. These persons then have to willingly agree to enroll in our program, engage in the services that we provide, and take an active part in improving their health outcomes. I say their health outcomes because we are strength-based and we empower our clients to determine their health outcomes. They have to be willing and ready for change because it is not us. It is them taking charge of their health. The services provided are on an individual basis as well to cater to each client's specific needs. No man is an island, however, and sometimes, believe it or not, family health issues may be more taught in the family becoming their culture of practice bad habits than actually passed through genes. And so, with permission from the clients, we engage family units and birth fathers, as well as getting them actively engaged in services as a family unit. This fulfills our mantra of building a healthy community one person at a time, one family at a time. How Apple came to us? Well, Apple came to us for services in a matter that we would often get our referrals. It was right after her initial visit to maternal child health and finding out that she was pregnant. Apple was going to be referred to us by the MCH clinic. As she was in the clinic, and presented as being in a crisis high-risk pregnancy with health concerns and some depression. But things escalated, however, and Apple began to express thoughts of possible self-harm and ending her life upon finding out that she was pregnant. You see, and when I speak about Apple, I want you guys to think about what you previously heard from the presenters and how she is a typical person that we see day to day and how the statistics is playing out here. So, Apple was a 29-year-old Black, Hispanic, single mother of 5 boys. And they were becoming overwhelming to her. She had her first child at 15 years old. And she expressed that things at home for her were just rough. Her role as a real parent to her children, she felt it was diminishing each day. At that time, she expressed that she was not able to see about the education of her youngest 2 children at their school because the school had placed a restraining order against her, adding to her parenting challenges. Her 14-year-old was to repeat the 7th grade for the 3rd time. And he, along with the second oldest son, were refusing at times to even go to school. Apple was living in public housing and reported that she had never held a job in her life. And so money was always scarce and problematic to meet all the needs of the home. There was no table, little to nothing in the fridge, and the children sat on the floor of the living room as there was no real furniture. They would express to me, "See, there's nothing here. What we want to be here in this house for?" The oldest child expressed no desire to go to school as he had no real fitting school clothes. And he stated that he knew his mother could not afford to get him what he needed for school. Apple had not finished school herself. Her last attempted grade was the 8th grade. She wanted her kids to go to school, but she had not gone herself, and this intimidated her. The oldest son felt that it was okay if his little siblings got stuff so they could go to school. So he would do what he could to see to that. He stated that no one really gives big kids stuff to go to school. That kind of made me sad. But it's kind of true if we think about when we do school drives, it's for the little kids. But what about the big ones that we want to finish and what that education means to them? And so because he didn't have anything, he just would not go. He felt he had no support and that he could not talk to anyone about his family's struggles, for they would be getting into his family's business. He was having in school to look out for and help his mother in the midst of all that was going on, and was upset of the people that she would bring into their home. And that those people in the end that she thought would help did not help them at all. So he did not want to go to school, and he did not want to be inside the home either. He did, however, want something better and was ready for change. He had no problems coming to see me at Charles Howard's site because it was a familiar place to him, where his mother would take him and where he and his neighborhood friends would go to chase and catch chickens. And so things with us began. Apple reported that there was so much scarcity and lack in her childhood, and now it was in her home. So she had sad feelings about this as well as her health. Apple was obese at 300 pounds, and she had already been recently diagnosed with hypertension. Now she was being told that she was pregnant to have baby number 6 with all that was going on in her life. The children had different fathers with relationships involving domestic violence and leaving Apple with no support for the children. The father of baby number 6, he had just gotten sentenced to years in jail, and so he left Apple with nothing and no one. She was not very certain who her father was, and her mother had died while she was a child. The adverse childhood experiences and challenges in her life after her mother's death had caused her to disconnect from her family and her siblings. She expressed that at one time she had her brother living with her to be a role model to her boys, but he had run-ins with the law, engaged in illegal behaviors, and was ultimately murdered. Life for Apple at this time felt grim. She was angry and overwhelmed and expressed never having had anyone professionally to address or sort out all the emotions of her life, for her family members didn't want people in their business. What to do? After we collaborated with providers and ensured Apple and her children would be safe and that her state of being was safe, she continued to desire help. And so we enrolled her into our VIPHC program to provide her education and support services. A brief history and background of our program is as follows. The Virgin Islands Partners for Healthy Communities, or VIPHC, has had over 22 years of experience providing case management services in the Virgin Islands, and it continues to play a critical role in supporting recovery efforts, as well as COVID-19 prevention and mitigation strategies. In 2000, the Bureau of Maternal Child Health, the Health Resource Services Administration, HRSA, awarded then the Virgin Islands Perinatal Partnership, VIPP or VIPI, a Healthy Start to a grant to address the disparities that at the time was impacting birth outcomes and to address the high rates of infant mortality in the U.S. Virgin Islands. Collaborative partnerships were formed with Frederiksted Health Center, the Maternal Child Health Clinic, VI Department of Health, and the Wang Louis Hospital to develop an effective perinatal system of care that could aid in diminishing the disparities. The approach incorporated an evidence-based model of case management, a consumer consortium, outreach, and facilitating access to services, which was instrumental. We were able to see positive outcomes in the reduction of infant mortality. From 10.8 deaths per 1,000 live births in 1997, it was reduced to 4.2 per 1,000 live births by 2004. Local residents diagnosed with chronic diseases of hypertension and diabetes were also added to the populations to be served by 2004 and 5 with the same goals of addressing disparities and improving health outcomes for our underserved residents. Over the years, utilizing community outreach, care coordination, case management, Medicaid enrollment assistance, social marketing, referral services as well, VIPHC has achieved the following goals: increasing access of uninsured and low-income families to public insurance, increasing access of targeted population to family-centered, comprehensive, coordinated systems of care, and reducing the rate of preterm birth and negative outcomes among the targeted population diagnosed high-risk pregnant or with the chronic diseases of diabetes and hypertension. Currently, VIPHC has collaborative partnerships with Frederiksted Healthcare Incorporated, the Virgin Islands Department of Health, the St. Thomas East End Medical Center, and the hospitals on both islands. Provider partners also include a cohort of clinicians, providers, health educators, private practitioners, government entities such as VI Department of Human Services, Housing Authority, the Social Security Administration, and private nonprofits such as St. Croix Foundation, Community Foundation, Women's Coalition, Family Resource Center, and Community First. So that is a synopsis of our program. You may be wondering how things might have gone with Apple, but if you can apply some of what I just said of our program to her story, you can imagine the work that had to and was done with her. The other clients and other clients like her. I must say, however, that this was work that Apple became willing and ready to do, and not just with herself, but with her family unit, for they were affected and they identified needed changes and were willing to reduce the disparities in their lives. Apple was ready for change. She'd always wanted a baby girl, however, and this pregnancy was a girl, so she was determined that she would have the baby and honor her commitment to always choose life, despite her health and other issues. And so we supported her in her choice. She just needed help, she felt. Apple's health issues resulted in her weight going up to 375 pounds in her pregnancy, placing her and the baby in a serious health crisis. But she did not give in to her negative circumstances. She continued with close medical care and apply the things she was learning about her health and her blood pressure, as well as her engagement in the services that she was referred to. And she went on to successfully have a healthy baby girl. Apple continued with VIPHC for advocacy, support, and education, and we at VIPHC watched many things transform for the better in her life and that of her children. Apple, with encouragement and advocacy, engaged in her children's school. For herself, she advocated appropriately for her children. They were able to respectfully address each other in their family and identify the needs that they have to each other, and they too learned how to have healthy lifestyles and environments. Apple felt particularly happy in becoming empowered to advocate for her oldest son with positive support. The school, very surprised, responded positively, and her son was able to get all he needed. And to all of our amazement, he worked really hard, and the school year ended with him actually graduating from the 8th grade, and her receiving this letter that he would be going to high school. Sorry. I guess I became so. I will stop here to talk about myself for a spell. I love people, and that's why I've been a social worker for so long. I have an open door policy because this is not cookie cut, and life is messy, and clients come in how they come, but you always respect them, and you find out what it is they want out of life, and then you and them can walk together because the aim is for them to be able to walk by themselves and help someone else. And with my open door policy, my pregnant girls, they set goals for themselves, 5-year goals. And they're not gonna achieve it in that small space of time, but my door is open. So they might say, look at what I did. This is a safe place that I can come and celebrate my accomplishment. Or this isn't working out, what should I do? We can restructure the goal and go forward. And so their success for me is my joy. Getting back to the story. So, Apple came in that day to me waving a paper, wanting to clearly understand what it meant. She wanted to be sure it was actually real. She expressed her fears, for she had not gone that far in high school, and it was scary for her, but she felt, it's okay, I must let him go on and go to do better. For her, for that should be the expectations of parents for their children, rather than them feeling less than because their children are going further than they have gone. They should be happy that their children are able to excel. And she could find peace in her heart to now do this. She would support her son positively through this time, and he would show her grace where she did not understand, and they, as a family unit, had begun to grow in a positive direction. He was able to graduate and go on to high school. Apple was able to learn about herself and her health, and she engaged and accessed needed services through referrals. She developed healthy life plans, life skills, healthy habits, as well as resilience tools for her life toolbox. She went on to set life goals for herself, and now she had practical ways to achieve them. Today, Apple has lost over 175 pounds. She has had her blood pressure readings normalized and has a medical home to where she no longer has to take medications, but is followed by a doctor. She was able to reconnect with her children's schools to advocate for them, as well as to reconnect with safe persons in her extended family for support and guidance, allowing for a safety net for her children outside of her neighborhood. She was able to get her first ever job and kept it for over 2 years. She got her driver's license, which allowed her access to a vehicle that she could use to better get around. She was doing things and she had goals. She was proud of herself. She was able to address her family's pains through engagement in services and felt empowered to make mature decisions for herself and her children and the well-being of their family. Apple has deeply changed the overall direction of her family and their overall health for the positive. She has now most recently gone on to a better paying job and sits and plans in anticipation for this school year of attending the first high school graduation of her little family unit. She feels very proud of their accomplishments, and we at VIPHC do as well. As I close, the one pivotal thing that I wanted to point out was that Apple lacked one disparity, only one, in that she had easy access to walk to health care. And Charles Harwood had become a place of comfort for her. She had over time become familiar with that, and she could initially seek the help that her family needed. That access proved to be a pivotal thing that opened doors to so much more positive things, resulting in that family's life and a life forever for her family. We were and are happy over the many years to work collaboratively and intimately with clients such as Apple and community partners in empowering and assisting those that come to us for services in ways that improve their health, but also positively affect impactful changes to their overall health outcomes. We collaboratively work together for and with clients to improve the lives and health equity of their families and themselves, affording them opportunities to achieve their best health. And that touches more than just the individual in that it passes on positivity to no extent to their families and ultimately to our community as a whole, raising the collective standard of our living and existence. Thank you for hearing my story.
That was very moving and empowering. Ms. Augustus, thank you so much. You know, she walks the halls of Charles Howard looking really quiet and not saying much. And the extent of the contribution, the tie into the family and the importance and using Apple as a that is amazing to me as a professor. So I appreciate that approach, and I really, really thank you and VIPHC for everything that you do. Commissioner?
I too want to thank you. Yesterday, Dr. Baumann had her cluster meeting and actually spoke about what you do. And one of the things that we spoke about case management and care coordination and how much you have been able to do with those two skill sets. And it's proven today what you can do. And partnering with you would be great. So thank you for your continued partnership and participation.
Thank you, thank you. Our next presenter is none other than Bobby Thompson from the HIV STD program. And again, we do have a bio in the program. And are you ready? Because I could spend the time. Okay, so we need a minute to set up. So let me introduce to you Oh man, Bobby, I don't have your bio. So all I remember is that I was teaching at UVI and this young man shows up in my Disparities course, you know, and it took me like half the semester to realize who he was. I'm like, I remember you because my daughter went to that clinic when we were growing up. So Bobby, I am really, really proud of what you are and your progress. And look at, we've come full circle. It was a Disparities course that we had participated in as your instructor, you as a student. So thank you for being here, and you can go ahead and introduce yourself and continue with your presentation.
All right, good, where are we at? Afternoon? Good afternoon, everyone. Let's see, the images, okay, looks like it came on. Can everyone see? Sorta, kinda? Okay, so I'll try to read the points for those who cannot see, and then the presentation will also be shared afterwards. Okay, so let's get real. HIV and the family. This is presented by Robert Thompson, myself. So I am the prevention coordinator for Communicable Disease Division. My director is Jason Henry, and the work that we do is, well, I'll go into it in a moment. Just a quick overview of the agenda. We're going to talk about the program overview and definitions, talk about activism and controversy in communicable disease work, talk about HIV and the family, break down some global, national, and local health disparities for local health disparities in key populations, and how we combat disparities through person-centered services, and then finally do a quick exercise in understanding bias and creating welcoming environments. We're going to get through it relatively quickly, so hang on. All right. So ending the epidemic, just to start off, Communicable Disease Division, we have 5 programs. That is the Ryan White Program, STD Prevention Program, HIV Surveillance, HIV Prevention, and Tuberculosis Control and Elimination. STD surveillance and prevention, of course, are very closely linked because we use the surveillance data to inform our prevention work, and our prevention work is where we get our surveillance data from. And the goal of our program is to get to 0. It's 340, getting to 0. And that's the chant that I want to get ingrained in everyone's head today. So when I say 340, what I want everyone to say back is getting to 0. Okay. All right, so let's try it again. 340. All right, okay. So we want to get to 0. That means 0 new infections for HIV for the year 2030. That also means 0 new infections for other communicable diseases that we have, that we're working with, right? Communicable diseases, there are wide, varied, many of them out there, so we're definitely working to try to reduce as much as possible. For HIV specifically, 90% of people living with HIV know their HIV status. 90% of people, their goals are for 90% of people living with HIV to know their HIV status, 90% of people who know their HIV status to receive treatment, 90% of people on treatment to have suppressed viral loads. By achieving these 3 goals, we'll be able to end the epidemic by 2030. So quick check-in with everyone. Is anyone having difficulty hearing me? Am I speaking too quickly, too slowly? Good? Okay. All right. All right, so the definition of health equity that we're going to be using for today is that it's achieved when every person has the opportunity to attain his or her full health potential, and so such that no one is disadvantaged from achieving this potential because of a social position or other socially determined circumstances. So that's the one that we're using for today. So about activism and controversy. Our work is often perceived as controversial. We definitely will be talking about some controversial items in this presentation. It's controversial because a lot of the populations that we work with are oppressed, are marginalized, and because of that, there are stigmas and biases against some of those populations, right? There's also specific stigmas against the people with the different diseases themselves, such as people living with HIV. So we're going to get into discussions on socioeconomic status, race, sexual activity, and pleasure, gender, drug use, sex work services. And so they're sometimes hard, but they're always necessary conversations to have. All right, so HIV and the family. So when it comes to our work and the family, it actually gets very complicated because we want to make sure that each individual in a family is treated equitably. Everyone in the family deserves to have equitable care. And where they can get complicated, for instance, is we have an obligation to provide confidential services. What this can mean is assisting, for instance, a minor with receiving confidential services, and that even if that is against the wishes of a parent who came to accompany them, right? That also means offering individualized plans. So let's say the minor has an individual personalized counseling session. However, they need the transportation of their parents to be able to move back and forth between appointments. I'll move on to, oops, sorry. All right, so I want to provide a little bit of context for some of the health disparities, and it's going to sound very familiar to Dr. Valmont for the health disparities class. All right, so some global trends in HIV. So for the World Health Organization recently released new guidelines on HIV, viral hepatitis, and STIs. In terms of key populations. Those key populations were identified as men who have sex with men, trans and gender diverse people, sex workers, people who inject drugs, and people in prisons and other closed settings. It's important to keep in mind that key populations doesn't mean that these are populations that are terrible, that are doing bad things, that are immoral. No, all it means is that these are populations that are most affected by HIV, or most affected by the viral hepatitis or STIs, and it's usually an issue of the various economic and social factors around people, the environment that is influencing and causing these highly disproportionate rates within these key populations. So for national trends, of course, we have racial and ethnic disparities. For Black, American Indian, Alaskan Native, Native Hawaiian and other Pacific Islander, and Hispanic and Latina people, we see disproportionately high rates of HIV. And that also I'll get to that in a second. For Asian people, there's actually disproportionately lower rates of HIV than for white counterparts. In terms of youth and age, we see that there are, if I can make this smaller, there we go. There are disparities between race, ethnicity, and reported behavioral risk factors, such as lower percentages of Black or Latina U.S. high school students reporting using a condom. For national trends for MSM, you can see right here that male-to-male sexual contact, men who have sex with men or men who love men, MSM have higher rates of HIV for Black, Hispanic, and white individuals than for their heterosexual counterparts, and that those rates are exacerbated also according to race and ethnicity. And then very alarmingly, for trans women, we have 62% in this survey right here, 62% of Black African transgender women had HIV in a survey that was conducted, 35% of Latina transgender women, and 17% of white transgender women, with an average of 42%. For transgender men and other non-binary genderqueer individuals, we don't have a lot of data for that, and that's an issue that is global, nationwide, and local. Oh, yeah. Okay. All right. So for pregnant women, there's issues with social and economic factors, especially poverty, creating barriers to health care that disproportionately affect people with HIV. Pregnant people may face more barriers to accessing health care and staying on treatment if they also inject drugs, use other substances, or experiencing homelessness or incarcerated, mentally ill, or uninsured. When we do collaborative projects and work with maternal child health and family planning. For sex workers, many sex workers also experience stigma, also experience poverty and lack of access to health care simply for their occupation. and may have a history of unemployment, incarceration, violence, emotional, physical, sexual abuse, drug use. So other issues that make it difficult to live your life. And of course, poverty. In one study, it showed that for people living in urban poverty areas, the HIV prevalence rate is more than 20 times greater than the rate among all heterosexuals in the US. So, of course, that's a huge factor. All right, so for local trends, our data is a little bit out of date. We are using data from 2014, that's our most recent epidemiological profile. However, in 2023, we're hoping to release a new epi profile, as well as a statewide coordinated statement of need. We'll be working with the IPG. We got some IPG members back there. Of course, one of the goals for the epi profile will be to reduce HIV-related disparities and health inequities. What I will say, though, is that we do have some figures from 2018. If you, for instance, are working on grants and you need to use these figures, I would definitely take a picture of them. I just want to let you know, though, that they may contain inaccuracies. They are not published for release. It's just to be shown for right here, right now, and so they may contain some inaccuracies. But within them, we see disparities, or we see implications for disparities locally for, men, for men who have sex with men, for Hispanic people, for, let's see, injection drug use, and alarmingly, there's, if you see in the bottom right there, we have 35.2% and 29% of people living with diagnosed with HIV infection and diagnosed with AIDS listed as unknown or not reported. Does anyone know why that might be alarming? Can you a little louder? Well, the reason why it might be alarming is that these all here are what people are reporting. This is the way that they got HIV. This is all for people living with HIV. But the issue is that if a third of people are not reporting, that means they're not trusting us as professionals to be able to report to us, right? Which means that there's definitely a huge barrier there in terms of us being able to get that access to the data that we need and then be able to provide the adequate services in exchange, right? All right, so how do we combat disparities? Well, the first thing we need to do is make sure that we're centered on the person. Person-centered care is about ensuring that people who use services are at the center of everything that you do. One of the ways that we're doing this is by trying to implement a status-neutral approach. What that means is that regardless of someone's status, whether someone's HIV negative or HIV positive, that means that they can get referred to the appropriate services that they need. So for instance, I know you can't really, probably can't see the text on here, but you can see that if someone tests negative for HIV, they can continue to receive preventative care such as PrEP, condoms, STD testing, continual HIV testing, and if someone tests positive, they can receive treatment, further STI care, condoms. So no matter what, you have the ability to receive treatment regardless of your status. Additionally, one lesson that really stuck with me when I was first starting work with HIV was when I went to training on condom distribution as a structural intervention. There was a discussion on the 3 A's, AAA services, right? In order to provide AAA services, we have to make sure that we're accounting for the availability, accessibility, and the acceptability of services. So in the terms of, for instance, condom distribution, are condoms available in the area? Yes. In terms of accessibility, can people actually go get them if they need to? Well, maybe not. Maybe you don't have a car and there's not anywhere that's nearby that you can walk to. Or maybe there is someplace nearby, but you don't have the money to afford condoms, right? And then you also have acceptability. If you pull out a condom and try to use it with a partner, will they accept the condom and allow for you to proceed with your sex? We take the AAA method with outreach to go with outreach testing. So we provide testing to the community to make sure that we're meeting people where they are. Let's see. And we're also trying to change the way that HIV is perceived through stigma reduction. We're going to show you a quick video on that we created. Let's see if the sound will work. Okay, so I'm having trouble with the video, so instead, we can just share the link afterwards. But the goal, the purpose of the video is that living with HIV today means living, and that the treatment is so effective. Okay, here you go.
That catch of a lifetime. For the chance to master a new dance. And to be ready for the road when the Fed returns. Today's antiretroviral therapy can keep HIV under control, keeping you healthy. Just one pill a day can lower the amount of HIV in the body, rendering the virus undetectable and unable to be transmitted sexually. If you or someone in your life is living with HIV and has not been receiving treatment, contact the VI Department of Health and step back into a healthy life. Get the care and support needed to keep living to the fullest. Because now, more than ever, living for today means living for so much more.
What cultural norms are, but also to be able to interact with clients, to be able to continue to learn, grow, and adapt. There's a video that I'm not going to show you today, but it's about language matters. For instance, instead of saying that someone is an addict, say that someone has a substance use disorder, because how you say or categorize people will end up affecting how those people are treated, either by their peers themselves or by the medical providers. For asking clients their pronouns. We talked earlier about how, although we don't have local figures, how nationally we have a huge issue with transgender women experiencing disproportionate burden of HIV infection. One of the ways that we can help to combat that is by asking for pronouns. So for instance, my name is Bobby Thompson, and my pronouns are he and him, right? That identifies both my name and then my gender, right? By doing that, all you do is identify that you are someone who is willing to accept someone who is transgender or is who is of a different gender diversity than you might be, right? And that can help to open up those services, because that can be the difference between, for instance, a Caucasian trans woman accepting services or choosing to walk away because they know that she's not going to be given the care that she needs. I'm just going to summarize these next points very quickly. Risk to reasons. There's a training by the drug manufacturer ViiV that the training itself is actually pretty good. It's on risk to reasons if you look it up. But the summary of it is basically, instead of when speaking and counseling with a patient, instead of looking for risks, ask for reasons. So for instance, instead of talking to a sex worker and saying, why are you having unprotected sex? Don't you know that is very risky? maybe try to figure out the reasons for, what are the reasons for why she or he chooses to engage with unprotected sex, right? Maybe unprotected sex allows them to charge more money, which allows them to be able to feed their family, right? So that when you're able to get the actual reasons, you can actually create an individualized, person-centered approach to whatever service you're providing to that person. And then just wanted to promote the fact that we're having an upcoming LGBTQIA+ training into communicable disease to help improve partner services and testing. So there's a lot of services that we provide. Our grants are focused on key populations as well. I have a quick exercise that I wanted to do. I think we're probably a little bit going over time. I don't want to take away from everyone else. So I will just give a quick synopsis of how you can get HIV with sex without a condom, pass from mother to baby, sharing injection drug equipment, and then how you cannot get HIV. That's from kissing, hugging, sharing food, insect bites, basically not from casual contact, right? You're not going to get HIV from sneezes, bathing, sweat, toilet seats, none of that. There's plenty of prevention methods and treatment methods available. Treatment is effective. Did want to do a values exploration exercise, but the basics of this is just that people have varying opinions, and attempting to understand a client's values is the cornerstone of client-centered services. Well, you could try the exercise yourself, maybe when you have time. But what it is basically taking a controversial statement and arguing both for and against, as if you were that person, and that helps you to try to understand the rationale that each person might have who defends or opposes that view. All right, so I went by pretty fast, but again, we'll be changing the presentation. Questions or comments?
Okay, Mr. Thompson, can you speak a little bit more about what your plans are in working with the different departments? You said you had an activities coming up. I think it's interesting for everyone to hear what that is and what the intent is.
Sure. So one of the really cool activities that we are doing is that, as we said before, we have an issue where men who have sex with men and transgender women are disproportionately affected by HIV, right? And one of the reasons for that, of course, is because of the various environmental factors. That includes stigma and the inability to access services that are actually apt for that person. So whether the provider actually knows about knows about that population, about that culture, or whether the person feels comfortable being able to even access services because they don't want to be discriminated against, right? So what we're trying to do is to reduce stigma and discrimination to be able to increase the amount of people who feel comfortable seeking services, especially among those vulnerable key populations. And one of the ways that we're doing that is by reaching out to various agencies, Department of Education, Division of Personnel, Department of Human Services, and we're having a talk with leaders to understand what are their views and their perspectives on the protocols for the internal agencies on how for LGBTQIA+ persons. In addition to that, we'll be, with the LGBTQIA+ training that we have coming up, we'll be training staff to be able to further train those agencies and staff and members so that we can eventually build an environment where we have reduced the stigma, not just against HIV, but against reduce the stigma for the populations and the demographics that are associated and heavily correlated with HIV infection. So thank you for the question. Any other questions? Yes. So the injectable medication is available anywhere. The issue is just kind of, a lot of providers don't feel comfortable prescribing it because they don't they would like more training on how to administer it and just more about the medication in general. The medication is available anywhere, but there's also issues, for instance, with navigating cost, and because there are programs, of course, for the pills, but for the injectables, there's some different things to work through. So, theoretically, yes, it is available, and you can be prescribed the injectable medications. Whether or not people are actually receiving those injectable medications, we're still working on helping to get to there. But that just brings us to a great point, which is that there are many varieties of treatment and prevention for medications, whether it's a pill a day or an injection a month or every 2 months. I think I saw there was another question back there. Yes. I don't think I need a mic. I'm pretty loud. Oh, for the recording.
Okay, so my question would be, how do you navigate HIV around the DL or more of the down low community? Because within the territory, we do have a large number of men who sleep with men, but are more secretive of it. Mm-hmm. So how do you navigate education and outreach around that? So for education and outreach for DL or down low men, it can be very difficult to often to reach DL populations. So definitely what we try to emphasize is that we have confidential, discrete services. One of the issues that we have is that because people who are DL are often very discreet, and because our community is so extremely small, that even though they may reveal their identity to like a very close friend, they will not reveal, no matter how much you tell them that the services are confidential, to a provider. You have, for instance, there are a lot of for instance, there may be DL guys who will only choose a sexual partner who is a tourist or someone who doesn't live on the islands because they're disconnected from our community and have less chance of exposing themselves. So in terms of outreach is trying to provide as confidential service as possible. In terms of partner services, that's one of the reasons why we really push hard to get the LGBTQIA+ training, is because we want to make sure that our disease intervention specialists and our community workers, our outreach workers, can provide as culturally competent care as possible. And in terms of the education, I think we actually could be doing more. We do provide, the LGBTQI training that we're doing, I think that will help to make the environment safer for DL people to be able to express themselves and be themselves. But in addition to that, I think that we probably need to do, for instance, targeted ads on various dating sites and things like that. That's a very good question. Other questions? Yes.
Thank you. Along the same lines of the previous question, can you talk to us about the outreach activities associated with the homelessness we see, especially like in Frederickstead, those who hang around the shops around King Street and Prince Street and Lagoon Street? Can you speak to outreach activities you have planned or you may have engaged in the past to meet the needs of that population?
Sure. So for Department of Health, for outreach testing, in the past we've definitely done activities directly for the homeless populations. Like for instance, we've done offer testing services and surveys, informational surveys at I forgot what's the name of the My Brother's Kitchen, My Brother's Table. Sorry, My Brother's Table. Sorry. And then for people who living with HIV who are also homeless, our systems are set up so that we have, for instance, vehicles and to assist with transportation and stipends and various things to help with nourishment, with making sure that people can get the support services that they need. Because of course, like, you know, if you're homeless, and someone's trying to get you to take your HIV medication, right? And you're banging against the wall saying, you know, why aren't you taking your medication? Well, maybe it's because the main priority is finding a safe place to sleep at night, right? Maybe they're not worried about that right now. So we try to incorporate as many support services as possible into our services so that we can assist with those populations as well. Great, thanks.
One of the things that we're doing in the Department of Health to help that also is, and you, DC Jabatisi and I have spoken about this, is basically the job description and looking at what we're doing now with our outreach workers. We have to be able to be accessible to the community 24/7. So doing outreach isn't from 8 to 5. We have to be able to get out there when everyone is out there, into the bars, into the nightclubs, into the activity centers. And so those are the things that we're doing more frequently to support not just the communicable disease division, but every entity. Behavioral health spoke about it, you know, and so we'll continue to hear that chime over and over again, proceeding. We are progressing to succeed. Thank you, Mr. Thompson. I really enjoyed that.
All right. Thank you.
That was a really good place to end, because if there's one program, many of our programs in the Department of Health conduct outreach, but this program, they are everywhere, and all you have to do is ask, and they are willing, and they came forward with COVID. So I just want to commend, you know, the HIV program. Director Henry is not here, but the entire team for the work that you've been doing. And again, tying into Department of Health strategic plans, we want to take health to where the people are. I mean, I was away and I saw that HIV had been at levels. You know, this is awesome. You know, so let's continue that mission. So at this point, again, I just want to say a big round of applause for everyone who has presented this morning. And can anybody guess that we are going to make a slight change to the program? We are going to break for lunch. And we will continue with the family presentation with Mr. Strawn right after lunch. Thanks for your flexibility. This is one thing we have learned with COVID. We know how to be flexible. So it's really critical. But however, the conversation was so enriching that it was really, you know, difficult to say or stop. But we really, really appreciate everyone else presented. So we're going to take a break for lunch. And we'll try to come back at 1:30 because that was the original plan. So we have 40 minutes for lunch. I think we can do this. I think we can do this. We have an announcement. Yes, so we are actually going to get up and go out to lunch in the beautiful restaurant, have gorgeous views. Please enjoy your lunch. And when we get back, I will have Director Fredericks make a quick announcement of some more activities that we have coming up, again, taking health to the community. And we'll have Mr. Strawn and continue with the program. Thank you, everyone, and see you in a few.